Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Youssef Elshimy. I'm a fourth year medical student, and today I'm gonna cover the anatomy and the physiology of the adrenal glands as well as the pancreas. So we're gonna first start with the adrenal glands, cover the anatomy, the histology, embryology, physiology, then we'll go over the diseases. Then we're gonna talk about the endocrine pancreas. We're gonna cover the anatomy, histology, physiology, as well as the diseases related to the endocrine pancreas. So let's start with the adrenal glands. The adrenal glands are basically two glands that are located above the kidney, which that's why they are called also suprarenal glands. And this terminology is very important when it comes to the blood supply of the adrenal glands because the arteries that supply the adrenal glands are called suprarenal glands, suprarenal arteries, sorry. So they are basically two small triangular shaped organs that are situated above the superior pole of the kidney. And they are basically endocrine glands, so they produce hormones, and these hormones get secreted into the bloodstream. The adrenal gland is divided into two distinct regions. We have the adrenal cortex, which is the outer shell, and then we have the adrenal medulla, which is the inner core. Starting with the adrenal cortex, we mentioned that it is the outer layer. It constitutes to 80 to 90% of the whole gland, and it produces certain hormones. Then we have the adrenal medulla, which is also the inner layer or the inner core, and it basically produces other hormones. So since these two distant regions have different functions, so they are derived from different embryological origins. For the adrenal cortex, it's derived from the mesoderm, while the adrenal medulla is derived from the neurocrest, which is an ectodermal origin. And we're gonna discuss more about the embryological origin for each, but just this is an intro. And what about the function of adrenal glands? The adrenal glands, as we said, they produce hormones. It's an endocrine gland. So these hormones regulate our body's metabolism, as well as the immune response, as well as controlling blood pressure and how the body reacts to stress. Okay, so the gross anatomy and the blood supply. We said that the adrenal glands are located above the two kidneys. They are considered retroperitoneal organs. You know, the peritoneum. They are behind the peritoneum, and they are surrounded by perirenal fat. If you remember from renal, the gyrotous fascia covers the kidney, as well as this fascia covers the adrenal glands. For the right adrenal gland, it is more of a triangular pyramidal shape, while the left adrenal gland is more of a semilunar crescent shaped. Um, in terms of vascularity, although it is a really small gland, it is one of the most highly vascularized organs in the body relative to its size. And this comes due to the heavy and rich arterial supply that it gets. So in terms of arterial supply, it is supplied by three arteries each. We have the superior and the middle and the inferior suprarenal arteries. And regarding the venous drainage, we have the right and the left suprarenal veins. The right suprarenal vein drains into the IVC because it's more closer to the IVC, while the left suprarenal vein drains into the left renal vein, and this left renal vein then drains into the IVC. Okay, we're gonna cover more talk more about the blood supply in details after a few slides. So in terms of relations, I want you to remember your basic anatomy, starting with the right adrenal. We mentioned that the right adrenal gland is situated on top of the right kidney, and it is more of a retroperitoneal organ. So what do we find, or what do we have on the right side? We have the liver and we have the IVC. So since it's situated, the right adrenal gland is situated behind. So in front of it, it would be the liver as well as the IVC. And behind, as you can see, behind the right adrenal gland, you have the right crus of the diaphragm. So just to recap, you have the right kidney. On top of it, we have the right adrenal gland. Since it's a retroperitoneal organ, it's more towards the back. So in front of it, you have the IVC and you have the liver. Behind the adrenal gland, you have the right crus of the diaphragm. This is for the right adrenal gland. For the left adrenal gland, remember the stomach, the spleen, the pancreas. So since it's also a retroperitoneal organ, it's on top of the left kidney, and in front of it you have the splenic vein as well as the spleen. Then you have also the pancreas and also the stomach, and behind it you have the left crus of the diaphragm. Okay, now talking more in details about the vascular supply and lymphatics. So regarding the arterial supply, we said that each gland receives three vessels or three arteries. You have the superior, you have the middle, and you have the inferior suprarenal arteries. So the superior suprarenal arteries, superior, it's above. And you know that the adrenals above it, you have the lower aspect of the diaphragm. So in order to remember it, basically the superior suprarenal artery comes from the inferior part of the diaphragm or the inferior phrenic artery. Okay? And the middle suprarenal artery, since it's in the middle, it's on the same level of the abdominal aorta. So it receives this branch directly from the abdominal aorta. And for the inferior suprarenal artery, what's under the adrenals is the kidney. So this inferior suprarenal artery comes from the renal artery itself. So to recap, you have the adrenal gland, it receives three blood supply, three arteries, superior, middle, inferior. Superior comes from the inferior part of the diaphragm, so inferior phrenic, because phrenic is the artery that supplies the diaphragm. So superior comes from inferior phrenic artery. Middle at the same level of the aorta, so it comes from the abdominal aorta, and the inferior comes from what's under the adrenal, which is the kidney. So it comes from the renal artery. Okay. For the venous drainage, there's a bit of difference between the right and the left, since the right adrenal gland is situated more close towards the IVC. So the right suprarenal vein or right adrenal vein drains directly into the IVC, while the left adrenal vein drains first into the left renal vein, then this drains into the IVC. Okay. And for the lymphatics, lymph basically drains into the para-aortic, like the lymph nodes between the aorta, para-aortic lymph nodes, as well as the paracaval lymph nodes. And this is important. Whenever a tumor or a cancer arises from the adrenals, and this cancer wants to spread throughout the body through lymphatics, the first lymph nodes that are gonna get affected or in which the cancer is gonna spread towards to is the para-aortic and the paracaval lymph nodes. Okay, this is just to recap. You can see the right adrenal, the left adrenal. It's more of a triangular here. It's more of a semilunar or crescent shaped. Each adrenal gland receives three blood supply. You can see that this is the inferior phrenic artery giving superior suprarenal artery. Then you have the abdominal aorta giving the middle suprarenal artery. Then you have the renal artery giving the inferior suprarenal artery. For the venous drainage on the right side, it drains directly into the IVC. For the left side, it drains first into the left renal vein. Then this left renal vein drains into the IVC. All right. Okay, so now we covered the vasculature part. Let's talk more details about the adrenal cortex. We mentioned that the adrenal gland is divided into cortex and medulla. Let's talk more about the adrenal cortex, which is the outer shell. The adrenal cortex itself is divided into three histological zones. Okay, it's divided into three zones, and these three zones are remembered by the mnemonic GFR. You know, because the adrenal gland is above the kidney, in order to memorize the three zones from outside to inside, use the GFR mnemonic. So what are the three zones? We have the zona glomerulosa, zona fasciculata, and zona reticulata. You have the G, the F, and the R. And each zone secretes specific hormones. So starting with the zona glomerulosa, it is the outermost layer. It produces mineralocorticoids, which includes aldosterone. And what is the function of aldosterone? It basically regulates the sodium electrolyte balance by regulating sodium and potassium as well as controlling blood pressure. For the middle layer, which is the zona fasciculata, it produces glucocorticoids, mainly cortisol. And from its name, glucocorticoids, it regulates the glucose metabolism as well as the long-term stress response. Finally, the innermost layer of the adrenal cortex we have the zona reticularis, which produces androgens like DHEA and as well as androstenedione. And the function of these androgens is that they are precursors to sex hormones. They are precursors to testosterone and estrogen. Okay. Then we covered the outer core or the outer layer, which is the adrenal cortex. Moving on to the adrenal medulla, which is the second part of the adrenal gland, which is the inner core. It is composed of chromaffin cells. These chromaffin cells act like a postganglionic neurons without axons. So basically, these cells are cell bodies of neurons that produce hormones. And these hormones are catecholamines. Catecholamines include epinephrine and norepinephrine. So epinephrine is also called adrenaline, and norepinephrine is noradrenaline. But what I want you to know is that chromaffin cells, they act as postganglionic neurons and they produce catecholamines. So what are these catecholamines? This includes the epinephrine, which is 80% of the output, and norepinephrine, which is 20% of the output. What are the functions of catecholamines? They basically trigger the fight or flight response. So in case of their sympathetic nervous system activation, this triggers the fight or flight response. So what happens, there would be increase in heart rate as well as blood pressure. There would be also dilation of airways to breathe, as well as mobilization of glucose for immediate energy utilization. Okay. One cool thing to notice about the blood supply of the adrenal cortex is that, or the adrenal gland, is that there is dual blood supply. For the cortex area, what supplies the cortex is, we mentioned the suprarenal arteries, right? Then this divides into capsular artery. And in order to supply the cortex, we have the cortical arteriole that then divides to form cortical sinusoids. Then these sinusoids merge back to form the adrenomedullary collecting vein. And this then ends up draining into the central adrenomedullary vein. Okay, this is the blood supply of the cortex. But for the medulla, you have the capsular artery that then branches into the medullary arteriole. And this medullary arteriole does not branch. It keeps moving in a straight line until it reaches the medulla, and then it forms the medullary capillary, and this then drains into the central medullary vein. Tamam? What I want you to notice is that the medullary area receives two blood supply. The first blood supply that comes from the cortex, and the second blood supply that comes from the capsular artery itself. Okay? Why is that significant? Because the second blood supply is the blood that nourishes the medullary cells. This is for nutrition. But the first blood supply is important because some hormones secreted from the adrenal cortex modulates or regulates things happening in the medulla. So, for example, the glucocorticoid secreted in zona fasciculata, it goes into the medulla and it stimulates the production of catecholamines. Not only this, but it also changes the norepinephrine to epinephrine. It acts on an enzyme that changes the norepinephrine into an epinephrine. So what I want you to understand is that this dual supply is important because one of these supplies, one of these vessels supply or nourishes the medulla itself. The other blood supply is basically hormones produced from the adrenal cortex that facilitates or modulates the hormones produced in the medulla. And there is like a connection between the cortex and the medulla. The glucocorticoids facilitate the production of catecholamines as well as the conversion of norepinephrine into epinephrine. Okay? Okay, embryology. So we mentioned that there's adrenal cortex, adrenal medulla, different hormones here, different hormones there. So since there are different functions, it means that they are derived from a different origin. So adrenal cortex, mainly they are derived from the mesoderm. What happens is that the coelomic mesoderm near the urogenital ridge moves and proliferates in between week 4 to 6 to become the primitive adrenal cortex. This is not the definite or the final, it's just primitive adrenal cortex. And by week 8, this cortex divides into an outer definitive cortex, which is a thin layer. And inside this cortex, we have a more of an inner fetal cortex that it's large and temporary. Okay, just to review. The adrenal cortex is derived from the mesoderm, from the coelomic mesoderm near the urogenital ridge, near the area of the kidney. Okay. By week 8, by week 6, 4 to 6, these mesothelial cells proliferate to form the primitive adrenal cortex. Week 8, this primitive adrenal cortex divides into an outer definitive adrenal cortex, which is the thin layer that we have as adults that does not regress. It stays with us, the permanent one, and the inner fetal cortex. This is a large and temporary layer. And this fetal cortex is important because it produces steroids during gestation and regresses after birth. This steroid is important for organ development and lung maturation and has a lot of functions during gestation. But after birth, خلاص, it regresses. What only stays is the definitive outer thin layer cortex. This is the cortex we have, okay? Then we have the adrenal medulla. The adrenal medulla is derived, it's basically a modified sympathetic ganglion. So it's related to the nervous system, sympathetic nervous system. So it's derived from the neural crystals, and the neural crystals are basically ectodermal in origin. Okay. And these develop alongside the sympathetic nervous system because we mentioned that it is a modified sympathetic ganglion. By week 5, these neural crystals migrate from to the para-aortic next to the aorta as well as the paravertebral. And these neural crystals, they get inside the medial aspect of the adrenal cortex. So this is the adrenal cortex. These are the neural crystals. What happens is that by week 5, they migrate and they get inside involuted by the adrenal cortex in order to become the adrenal medulla, and this adrenal cortex then becomes the outer layer definitive adrenal cortex. Tamam? Then these neurocrist cells differentiate into chromaffin cells that secrete secrete epinephrine and norepinephrine. Okay. Histologically, we mentioned that we have adrenal cortex, adrenal medulla. The adrenal cortex has 3 layers: zona glomerulosa, fasciculata, reticularis. Starting with the zona glomerulosa, it's the outer most layer. It contributes to 15 to 20% of the adrenal cortex. Okay, it's basically small cells that are arranged in rounded or curved clusters that resembles glomeruli. That's why it's called glomerulosa, because these cells are arranged in the way that resembles the glomerulus or glomeruli, the function unit of the kidney, and has a moderate amount of lipid content, okay? Then we have the largest layer of the cortex, which is the zona fasciculata. It contributes to 75% of the cortex, and it is made up of large foamy cells. It's foamy because it has a lot of lipid content, as you see. And these cells are arranged in vertical columns. Okay. Then finally, you have the innermost layer of the cortex, which is the zona reticularis. It is basically made up of compact cells, smaller cells, and they are eosinophilic with few lipid droplets. So you can see how pink they are because they are eosinophilic. Then we have the adrenal medulla, which said it's composed of chromaffin cells, and these chromaffin cells are important in secreting catecholamines, which includes epinephrine, norepinephrine. Okay, now let's move on to the physiology, starting with the adrenal cortex. Just to recap, we have the adrenal cortex is divided into 3 layers: glomerulosa, fasciculata, reticularis. Glomerulosa basically produces, think of salt, so mineralocorticoids, mainly aldosterone, okay? And the main function of aldosterone is to regulate sodium, potassium, as well as blood pressure. How is the secretion of aldosterone regulated? It's regulated mainly by the renin-angiotensin-aldosterone system. The angiotensin 2 acts on the zona glomerulosa to produce aldosterone, okay? And also sometimes when when there is hyperkalemia, or there's increased potassium in our body, this would lead to the production of aldosterone in order to excrete the extra potassium. All right? All right. Moving on to the middle layer, which is the zona fasciculata. We mentioned salt, then sugar. So it produces glucocorticoids, mainly cortisol and corticosteroid. What's the function of glucocorticoids? It regulates the metabolism as well as stress response, as well as immune activity. And how is it regulated? Basically, ACTH from the pituitary stimulates the zona fasciculata to produce glucocorticoids. So ACTH is the main regulator. Then we have the innermost layer of the cortex, which is the zona reticularis. It produces adrenal androgens, DHA and androstenedione. Also, sometimes it secretes small amount of cortisol. Okay, and how is it regulated? It's regulated by ACTH as well. So fasciculata and reticularis are regulated by ACTH, and zona glomerulosa is mainly regulated by renin, angiotensin, aldosterone system. All right. So these three layers, they produce steroid hormones. So what are basically steroid hormones? Steroid hormones are basically hormones made up from cholesterol, which is a 21 carbon steroid. As you can see, this is cholesterol. It's made up of 21 carbon compound, and it has the four labeled rings. You have the A, B, C, D, and you can see how they are numbered from 1 to 21. Since all of these hormones that we talked about are made up of cholesterol, what makes a hormone a glucocorticoid? What makes a hormone mineralocorticoid? What makes it androgens? So each steroid hormone has different structural differences. So for glucocorticoids, mainly cortisol, as you can see, it has a ketone group at C3, and it has hydroxyl groups at C11 and C21. And that what makes the steroid hormone cortisol or glucocorticoid. For mineralocorticoids or aldosterone, um, it has a characteristic double bond at C18. So having this double bond at C18 makes the steroid hormone mineralocorticoid or aldosterone. Then you have the adrenal androgens, which is the DHA as well as the androstenedione. Mainly, you can see the double bond oxygen at C17, and also it lacks the C20, C21 side chain present in other steroids. You can see the side chains here. It lacks this side chain, and it has a double bond oxygen at C17, and that what makes this steroid hormone adrenal androgen or androgen. Okay. We mentioned that cholesterol is very important for steroid synthesis, but how do we get the cholesterol, or how does adrenal cortex receive or get cholesterol in order to produce steroids? So basically, we have two mechanisms. We have the circulating lipoproteins and we have the de novo synthesis. The circulating lipoproteins contribute to 80% of the cholesterol that the adrenal cortex uses to produce steroid. So this comes from the LDL circulating in the blood. There is small contribution from the HDL, but mainly from the LDL that is circulating throughout the blood. It takes the cholesterol from it. Then we have the de novo synthesis. It means that the adrenal cortex itself produces cholesterol, and this contributes to 20% in adrenal cells. And mainly they are produced from acetyl-CoA. Okay. In terms of storage, the cholesterol that is taken from the LDL or produced by the adrenal cortex, they are stored as cholesterol esters in lipid droplets. And whenever the adrenal cortex wants cholesterol, either it replenish this cholesterol by taking LDL or from intracellular de novo synthesis. Okay. All right. So let's talk more in details about the steroid hormone synthesis. One thing to notice is that steroid hormones are synthesized on demand. So whenever the body wants, for example, glucocorticoids, it acts to produce glucocorticoids. Or whenever the body needs mineralocorticoids, it produces just whenever it needs. It does not continuously produce these hormones. Okay. So these hormones are not also stored in vesicles. So you cannot store these hormones. It's basically synthesized based on demand. Okay. So how are these hormones produced? We mentioned that cholesterol is a very important precursor for steroid hormone production. You can see that the star protein transports the cholesterol into the mitochondria, and this basically strongly regulates the steroid production. Not only this, but then we have the rate limiting step, which is the most important step, which is controlled by the enzyme cholesterol dismutase. Okay, or it's also called the cholesterol side chain cleavage enzyme, or the SCC enzyme. This enzyme converts cholesterol to pregnenolone, which is the first precursor towards producing glucocorticoids, mineralocorticoids, as well as adrenal androgens. Okay, so this is their rate limiting step. It is the enzyme called cholesterol dismutase. It basically cleaves off the side chains of the cholesterol. Okay. And this also is under the control of ACTH. So ACTH has a major role in regulating this step. Where does the steroid hormone synthesis happen? It happens in the mitochondria as well as in the smooth endoplasmic reticulum. Okay, so when the hormones are produced and we're done, we produce glucocorticoids, mineralocorticoids, androgens. What happens? These steroids are lipophilic, so they diffuse out of the cell immediately. And when they diffuse out of the cell, since they are lipophilic, they need to bind to protein to make it more hydrophilic in order to get transported in blood. So what happens is that these hormones, they bind to corticosteroid binding globulin or the CBG, or they bind mainly they bind like 90% of them, they bind to CBG, and like 5 to 7% they bind to albumin in order to be transported into the blood. Whenever they reach their target tissue, what happens is that these hormones, they get unbound from the complex, and then they diffuse easily into the cytoplasm because they are hydrophobic or lipophilic. So it diffuses inside, the hormone diffuses inside, and then binds to an intracellular receptor. It might be a receptor in the cytoplasm or even a receptor in the nucleus. So when it binds, it forms a hormone receptor complex, and this complex moves inside the nucleus. And in the nucleus, you have the DNA. DNA has sites for, it's called hormone response elements. This is the site in which the complex binds to it. And once this complex binds to the DNA, this leads to gene activation. And once there's gene activation, there's transcription, there's production of mRNA. This mRNA gets translated into protein, and this protein synthesis or protein production alters the cellular activity of the cell. Okay, let's talk about glucocorticoid synthesis. The main glucocorticoid in our body is cortisol, or it's also called hydrocorticosteroid. We said that it is mainly synthesized in zona fasciculata. Some of it is synthesized in the zona reticularis. I want to go to the diagram and let's follow how the cortisol is produced. First, we have the cholesterol converted to pregnenolone under the action of the cholesterol dismutase or the SCC enzyme, and this is under the influence of ACTH. What happens is that the pregnenolone can be converted to progesterone, and these two compounds get converted to hydroxypregnenolone and as well as the hydroxyprogesterone by the action of the 17-alpha hydroxylase. Okay. The 17-hydroxypregnenolone gets converted to 17-hydroxyprogesterone by the enzyme 3-beta hydroxysteroid dehydrogenase. Okay. So this 17-hydroxyprogesterone is then converted to 11-deoxycortisol by the action of 21-beta hydroxylase. Then finally, 11-deoxycortisol is converted to cortisol by the action of 11-beta hydroxylase. So moving back, cholesterol is the first step. It's converted to pregnenolone by the action of the cholesterol dismutase or the SCC enzyme. Then the pregnenolone is converted to hydroxypregnenolone by the action of 17-alpha hydroxylase. Then the 17-hydroxypregnenolone is converted to 17-hydroxyprogesterone by the action of the 3-beta hydroxysteroid dehydrogenase. Finally, the 17-hydroxyprogesterone is converted to cortisol by two enzymes, the 21-beta first, then 11-beta hydroxylase. Okay? So, additional points is that not only cortisol has the glucocorticoid activity, corticosterone also has a glucocorticoid activity. So in case, for example, you have a deficiency in the enzyme 17-alpha hydroxylase, these metabolites are going to be shunted to this pathway. So pregnenolone and progesterone cannot be shunted to the glucocorticoid pathway. But luckily, throughout this pathway, you're gonna produce corticosterone, which has a glucocorticoid activity. So in case the 17-alpha hydroxylase is deficient or absent, corticosterone can still be produced. And therefore, life can be sustained without cortisol because we already have corticosterone, okay? But if there are enzyme defects that neither produces corticosterone or cortisol, this would be a critical and even can affect life. You cannot survive without cortisol or corticosterone. So if there's defect in the cholesterol dismorase, or there's defect in 3 beta hydroxy steroid dehydrogenase, or 21 beta hydroxylase, or 11 beta hydroxylase, all of these would prevent the production of corticosterone as well as cortisol. So these enzyme defects would block the production of both cortisol and corticosterone. One thing to notice is that some medications they affect certain enzymes. For example, mitrapone, it inhibits 11 beta hydroxylase, which is the final step of converting 11 deoxycortisol into cortisol. Another thing is ketoconazole. It inhibits multiple steps, from which it inhibits also cholesterol dismorase. So it affects the glucocorticoid production. Okay. All right. So we produce glucocorticoids, alhamdulillah. What are the functions of glucocorticoids? It has effects on metabolism as well as stress response. So regarding metabolic effects, so what happens is that you're in stress, or you need glucose in your body. So what happens is that there's increased gluconeogenesis. The body wants to produce glucose. What happens is that there's increased liver glucose production. And this happens from the amino acids and glycerol metabolites. And how do we get amino acids and glycerol? There would be increased proteolysis. So there would be increased muscle breakdown in order to produce amino acids to be used for gluconeogenesis, as well as there would be lipolysis in order to increase the fat mobilization for energy. And also a permissive effect is that glucocorticoids, they enhance the glucagon activity as well as the catecholamine activity, because they fall under the same family of stress and fight or flight response. So they work together in order to increase blood sugar and do the effects, or have a response to stress. Okay. Regarding the blood glucose regulation, it decreases the glucose uptake in the peripheral tissue. So because it wants to raise the blood glucose levels in the blood, so it decreases the uptake in peripheral tissues, and this effect causes diabetes. It's a diabetogenic hormone, because if it decreases the utilization of the peripheral utilization of glucose, blood glucose levels would rise and continue rising and would stay constant. So this would lead to diabetes later on. Also, it increases appetite. Why? Because in stress, you need energy, you need glucose, so it raises your appetite and makes you feel hungry, as well as it has effects on the bone and connective tissue. So it decreases the osteoblast activity, and the osteoblasts are important in bone formation. So this would lead to decreased bone formation and unopposed bone resorption. So as an effect, this would lead to osteoporosis, also bone fractures. So it would affect the bone homeostasis. Also, it would affect the collagen synthesis because it decreases the fibroblast activity. Fibroblasts are important for wound healing, for producing collagen. So glucocorticoids decrease the collagen synthesis, and this would lead to poor wound healing as well as striae, because basically striae is because of the thinning of the skin, you can see visible blood vessels on your body. And this is due to decreased collagen synthesis and also decreased fibroblast activity. All right. And glucocorticoids has a lot of anti-inflammatory effects, as well as immunosuppressive, as well as cardiovascular effects. So regarding the anti-inflammatory and immunosuppressive, it basically inhibits phospholipase A2. And by inhibiting this, you're going to inhibit the production of leukotrienes and prostaglandins. These play a role in inflammation. By inhibiting phospholipase, you would decrease the leukotrienes as well as prostaglandins. What else? It decreases pro-inflammatory cytokines, things like TNF alpha, interleukin 1, interleukin 2, interleukin 6. All of these play a role in inflammation. If you decrease these cytokines, there would be immunosuppression or anti-inflammatory effects. Okay. Then by blocking interleukin 2 is important for T cell maturation. So by blocking interleukin 2 or decreasing interleukin 2, this would lead to the decreased T cell proliferation, and you know that T cells are important for the cell-mediated immune response. So by giving glucocorticoids or by having increased glucocorticoids, this would lead to a drastic decrease in the cell-mediated immunity. It also blocks histamine release from mast cells. And you know, histamine is important in inflammation as well as allergic reactions, allergic responses. So by blocking histamine release from mast cells, this would lead to decreased allergic responses. Also, it affects the WBCs. It causes neutropenia, sorry. It causes eosinopenia as well as lymphopenia. So as an overall effect, it causes anti-inflammatory effects as well as immunosuppression. And this is why we take medications for autoimmune diseases and for allergies. We give also steroids or glucocorticoids to decrease the allergic reaction. For the cardiovascular effects, it has an effect on increasing blood pressure. And how does the glucocorticoids do that? They basically upregulate the alpha adrenergic receptors that are found in the arterioles. So by upregulating these receptors, more catecholamines are going to act on these receptors. So this would lead to more vasoconstriction, as well as it inhibits the production of nitric oxide. Nitric oxide is important for vasodilation. If there's decreased effective nitric oxide, there would be a decreased vasodilation, more vasoconstriction. So this is how it increases blood pressure. Also, at very high concentrations, the glucocorticoids, because they have similar structure to mineralocorticoids, they would act on the mineralocorticoids receptors, and they would lead to water retention and increasing the blood pressure. Okay, we covered the glucocorticoids. Now moving on to adrenal androgens. So basically they are produced in zona reticularis and partly zona fasciculata of the adrenal cortex. We said that it produces DHEA as well as androstenedione. We're gonna talk about the synthesis pathway, but basically it's derived from the 17 hydroxypregnanolone as well as 17 hydroxyprogesterone. What happens is that you remove the carbon 2021, you cleave it by the 1720 lyase enzyme, and by doing that, you produce the androgens. What is the physiological role of these androgens? They have weak androgenic activity because they mainly serve as precursors for other sex hormones like testosterone and estrogens. For the clinical significance, uh, in males, it has a minor role because, you know, males have testes and testes are the main side of testosterone production. So they don't need that much of androgens from the adrenals because they already have testes and these testes produce testosterone. For the females, it has a major effect because it is the only source of androgens for the females because the females, they do not produce testosterone from, they don't have testes. So the main source of adrenal androgens uh, are important for the females more than males. And regarding the regulation, they are regulated by the ACTH, just like the glucocorticoids. Okay, so let's go to the pathway. We see it has the similar pathway of glucocorticoids, but the 17-hydroxypregnanolone is converted to DHA by the 1720 lyase. So basically, this enzyme cleaves off the carbon 2021 chain. Then the 17-hydroxyprogesterone also gets converted to androstenedione by 1720 lyase. Okay. We mentioned that the main adrenal androgens are DHEA and the androstenedione. We said that they are weak androgens, they are mainly precursors for testosterone in males and estrogen in females. The physiological role in of androgens are major in females because they are major source of androgens, and androgens are important in females for pubic, axillary hair, libido, estrogen synthesis, as well as muscle buildup. For males, it's a minor contribution because already testes, they produce testosterone. And we mentioned that androgen production is controlled by ACTH. Okay, moving on to the third um, steroid hormone, which is mineralocorticoids, where basically they are produced in the zona glomerulosa, which is the first layer, and the main mineralocorticoid is the aldosterone. For the pathway, It's similar also to the glucocorticoid synthesis. So, but the final step is the conversion of corticosterone to aldosterone, and this happens by the enzyme aldosterone synthase, which is only present in the zona glomerulosa. Okay, let's go on the pathway. You can see that pregnenolone is converted to progesterone by 3 beta hydroxy steroid dehydrogenase, then progesterone to 11 deoxycorticosterone by 21 beta hydroxylase, then 11 doc converted to corticosterone by 11 beta hydroxylase. Finally, the final step, which is the conversion of corticosterone to aldosterone by aldosterone synthase. And this is regulated by angiotensin 2, which is why angiotensin 2 is important in producing aldosterone. Okay. Someone might ask, why don't the zona glomerulosa produce cortisol? Because it has a shared pathway. The answer is that the zona glomerulosa, it lacks this enzyme. So if it lacks 17 alpha hydroxylase, all the metabolites will get shunted in this pathway only. It cannot go and produce cortisol. Not only this, but also corticosterone, although it has a glucocorticoid activity, it directly gets converted to aldosterone by aldosterone synthase because it's found in the zona glomerulosa. So corticosterone is converted to aldosterone due to the presence of aldosterone synthase. One thing to notice is that some steroids have mineralocorticoid activity, which is the 11 doc as well as the corticosterone. So even if you're not producing aldosterone, you still have some mineralocorticoid activity by the corticosterone as well as the 11 doc or the 11 deoxycorticosterone. So for example, if there's a defect above DOC or doc here, this is doc. If there's defect above doc, there would be no mineralocorticoids produced at all because you cannot produce DOC, nor corticosterone, nor aldosterone. But if there is, for example, a deficiency below DOC, which is, for example, 11 beta hydroxylase, you can still produce 11 deoxycorticosterone or DOC. So, and this has also mineralocorticoid activity. So you can live with having the DOC hormone. Okay. Um, So we produce mineralocorticoids or aldosterone. What are the main functions? We mentioned that the primary function is maintaining electrolyte balance by reabsorbing sodium, excreting potassium as well as hydrogen, and maintaining blood pressure. How does that happen? It acts on the kidney, so it leads to sodium reabsorption. And this happens on the distal convoluted tubule as well as the collecting duct. What happens is that there's increased sodium retention in the body, and with reabsorption of sodium, water follows. Okay. If there's salt that goes, water goes with the salt. So that's how water follows, and then the blood pressure as well as the volume increases. Regarding the potassium and the hydrogen, they would be excreted, and there are some molecular mechanism. Basically, the aldosterone increases the sodium potassium ATPase pump in the tubular cells, as well as it increases the apical sodium channels, as well as it increases the sodium potassium chloride co-transporter activity. You can see the principal cells here. It increases the sodium channels for reabsorption, as well as the potassium channels for excretion. Also, it increases the sodium potassium pump for the gradient. For the integrated cells, it decreases the hydrogen ATPase activity to excrete hydrogen. Okay, so what are the functions of aldosterone? We mentioned the primary function. It also has secondary effects, which is the expansion of extracellular fluid. So basically, by reabsorbing sodium, you are expanding the extracellular fluid, and this supports the vascular volume as well as the blood pressure stability. Regarding the clinical relevance, in case of aldosterone deficiency, you cannot reabsorb sodium. So not absorbing sodium also will not reabsorb water. So you would have hypotension. And since water is not reabsorbed and lost, you would have dehydration. Since the sodium is not reabsorbed, you have hyponatremia. And also you have hyperkalemia because the potassium is not excreted. And all of these can be fatal. In case if there's excess or increased aldosterone, then you would have exaggerated effect of mineralocorticoids. So we'd have more fluid reabsorption. So we'd have hypertension, volume overload, hypokalemia, as well as metabolic alkalosis because hydrogen ions are being excreted outside. So, as a summary, mineralocorticoids, they control the sodium, potassium, as well as the hydrogen balance. They maintain the extracellular fluid volume as well as blood pressure. And these mineralocorticoids are essential for life-sustaining fluid homeostasis. Okay. Now we have some conditions in which there are key enzyme deficiencies, and this would lead to congenital adrenal hyperplasia. So, congenital adrenal hyperplasia happens when there are congenital defects in some enzymes, and this would lead to the hyperplasia or the growth of the adrenal gland. And we're going to discuss each enzyme defect. We have the 21 hydroxylase deficiency, which is the most common, around 90%. We have the 11 beta hydroxylase deficiency, and we have the 17 alpha hydroxylase deficiency. So, starting with the 21 hydroxylase deficiency, which is the most common, let's have a look. If this is not working, what would happen? The metabolites would get shunted. You see this pathway. The pathway for producing aldosterone as well as cortisol is affected. So what would happen is that these metabolites are going to be shunted towards the androgen production. So let's go back. So what happened? There's decreased cortisol as well as aldosterone. What happens is that since these are decreased, there would be no negative feedback towards the pituitary. So there would be increased production of ACTH, and that what causes adrenal hyperplasia because ACTH has a growth effect on the adrenal glands. So there would be a huge adrenal hyperplasia, as well as in order to diagnose this condition, there would be elevated 17-hydroxyprogesterone. You can see that the metabolites are shifted towards the androgen pathway, but as they get shunted, you can see that the 17-hydroxyprogesterone increases because it cannot get converted to 11-deoxycortisol as well as cortisol or corticosteroid and cortisol. So this would lead to the increased production of 17-hydroxyprogesterone, and this is diagnostic. If you want to diagnose someone with 21 hydroxylase deficiency, you would find that he has or she has increased 17-hydroxyprogesterone, and there would be increased androgen because we mentioned that metabolites are gonna be shunted towards the androgen pathway. What would be the clinical feature? There would be salt wasting crisis because there is no aldosterone production, so the salt is going to be excreted as well as fluids. So there will be salt wasting crisis. In females, there will be ambiguous genitalia at birth or virilization because there's increased androgens. These affect the female genitalia and make it more towards the shape of the male genitalia. So this what is it called, the virilization. For both sexes, you have precocious puberty and short stature, and this is due to the exposure of increased androgens. This is the most common enzyme deficiency. Okay, for the 11 beta hydroxylase deficiency, have a look here. So here it's decreased or the enzyme is not working. So what would happen is that also metabolites are going to be shunted to the androgen side. But something to notice is that you can still produce the 11-deoxycorticosterone or DDOC. So what would happen? Still, there's decreased cortisol, so there would be increased ACTH, so there would be adrenal hyperplasia, but there would be production of 11-deoxycortisol as well as DOC, and there would be increased production of androgen. So what would be the clinical features? We mentioned that the DOC has mineralocorticoid activity, so there would be exaggerated aldosterone effects. So they would have hypertension, hypernatremia, hypokalemia, metabolic alkalosis, and also since they have androgens, there would be virilization in both sexes. The last enzyme, which is the 17-alpha hydroxylase deficiency, as you can see here, if this is not working, then all metabolites are gonna move towards the aldosterone pathway. So what would happen is that there is decreased cortisol and androgens, and this happens because you cannot shift the metabolites towards the glucocorticoids production or the androgen production. So this would also lead to an increased ACTH. That's why you have adrenal hyperplasia. And the metabolites are going to be shunted towards production of mineralocorticoids. So there would be increased production of corticosterone as well as DOC, as well as aldosterone. So what would be the clinical feature? There would be hypertension, hypokalemia. Also, there would be sexual infantilism or absence of the secondary sexual characteristic because there is no androgens. So especially in the females, the androgens are important for secondary sexual characteristics like pubic hair, axillary hair, libido, as well as libido is sexual drive, as well as like muscle mass. So just to review the pathophysiology concept, basically you have a defect in an enzyme, and this defect in enzyme would lead to decreased cortisol secretion. And if there is decreased cortisol secretion, there would be loss of negative feedback. So nothing is inhibiting the pituitary. The pituitary is going to increase the production of ACTH, and this would cause adrenal hyperplasia, as well as the precursors that are before this enzyme. This is the enzyme that gets blocked. The precursors accumulate. So this could be used to diagnose conditions. For example, the 21 alpha or the 21 hydroxylase deficiency. What would happen is that there would be accumulation of the 17 hydroxyprogesterone. This is diagnostic. Not only that, but these precursors or the precursor metabolites would get shunted into alternative pathway, like for example, androgen production or mineralocorticoid production. So this is basically the pathophysiology concept, and it's basically summarized here. If you want to go over it, I think I covered most, if not all. Um, this is a good review. Okay, so let's talk more about the adrenocortical cortical hormone regulation. How are these hormones regulated? We mentioned that the steroid hormone synthesis in the adrenal cortex, they require ACTH stimulation, and we mentioned that ACTH is important for the first step, which is the conversion of the cholesterol to pregnenolone. And this step is the first and the rate limiting step for steroidogenesis. Without ACTH, you cannot produce adrenocortical hormones. But there are two major regulatory systems that control the adrenal cortex. We have the hypothalamic pituitary adrenal axis, or the HPA axis, and this regulates the zona fasciculata as well as the reticulata. So what happens is that ACTH acts on the zona fasciculata in order to produce cortisol, and ACTH acts on the zona reticularis to produce adrenal androgens. Okay. For the renin-angiotensin-aldosterone system, the angiotensin 2 acts on the zona glomerulosa to produce aldosterone. So, but one thing to note is that ACTH is required for the initial step of the steroid synthesis, but aldosterone secretion is primarily controlled by the RAS. So, what's the first step? Is the conversion of the cholesterol into pregnenolone. This is the first step. After that, all is controlled by the RAS or the renin-angiotensin-aldosterone system to produce aldosterone. The other two hormones, the cortisol and the adrenal androgens, are controlled 100% by ACTH from the first step till the last step. Okay. This is the hypothalamic pituitary axis. It regulates the cortisol secretion. What happens is that whenever there's stress, it acts on the hypothalamus. The hypothalamus then releases CRH, or the corticotropin releasing hormone. This CRH acts on the anterior pituitary. It acts on the corticotropes in order to produce ACTH. This ACTH then goes to the adrenal gland to act on it and to produce cortisol. So these CRH neurons, they originate from the paraventricular nucleus of the hypothalamus. And these CRH, this CRH produced, it basically stimulates the corticotropes in the anterior pituitary to produce the POMC. And this POMC gets cleaved into ACTH, the one that is used to stimulate the adrenal cortex. Also, it gets cleaved into beta lipoprotein as well as the beta endorphin. Other points, the ADH that gets released from the posterior pituitary also enhances the CRH mediated ACH release. As I said, the ACTH has a trophic or a growth effect on the adrenal cortex, and that what happens in adrenal hyperplasia. In adrenal hyperplasia, there's increased ACTH, and this would lead to the growth of the adrenal cortex. or the adrenal gland. How does negative feedback regulation happen? We mentioned that cortisol, there's a negative feedback done by the cortisol. So the cortisol itself can go to the hypothalamus and inhibit the CRH secretion. It could go to the hippocampus, which are the in the upper centers, and control the hippocampal neurons that inhibit hypothalamic CRH release. Also, it controls directly or acts directly at the anterior pituitary at it, and by this it will inhibit the release of ACTH. So if there is decreased cortisol, this would lead to increased CRH and ACTH release because there is loss of negative feedback. But if there is increased cortisol, خلاص, you have enough cortisol, there is no need to produce more cortisol. So this would lead to the suppression of CRH as well as the ACTH. One thing to notice is that ACTH is derived from POMC, and POMC is also produces melanocyte stimulating peptides. So in case of there's excess ACTH, this ACTH would bind to melanocortin receptors on the melanocytes, as well as the byproducts of PMC would lead to the stimulation of these receptors, and this what causes hyperpigmentation of the skin in case of, for example, Cushing's disease. And we're going to discuss it more. Okay, let's talk about the diurnal secretion of ACTH and cortisol. So we said that the hormones are produced on demand. So whenever you need them, you produce them. So the ACTH and the cortisol are secreted in pulsatile bursts throughout the day. They are not continuously secreted. They are secreted in bursts and or pulsatile manner. Approximately, they are secreted 10 times throughout the day. And the peak secretion, or the level in which the cortisol is the highest, is in early morning, like the moment you like wake up in early morning around 6 to 8 a.m. And this happened because, beginning of the day, you're exposed to stress, for example, work and uni, and it's a stressful thing. So that's why in the early morning, the cortisol as well as the ACTH peaks. But it's slowest during evening and early sleep because, at the end of the day, you're already relaxed, you're tired, there's nothing to stress, and you're gonna go sleep. So it is the lowest in evening and early sleep. Okay. So 75% of cortisol secretion occurs between 4 a.m. to 10 p.m. And this is the time in which the stress is the most. And that's why cortisol peaks or secretion the most happens. And you can see that ACTH and cortisol, they are proportional. So whenever ACTH increases, it acts to increase the cortisol. Whenever the cortisol is enough, it decreases ACTH in order to decrease cortisol secretion. So they are complementary. And we use the salivary cortisol to measure the free cortisol that is found in our body. And this has a clinical relevance. We're going to discuss it in a few slides. Okay. One thing to notice about the regulation of aldosterone, since it's regulated different than the glucocorticoids as well as the androgens, we mentioned that it is mainly controlled by the RAS. What are the major stimuli for aldosterone secretion? First is the decreased blood pressure or blood volume. So whenever there's decreased blood pressure or blood volume, the kidney is going to sense this, that there's not enough blood coming through the kidney. So this would get sensed by the macula densa. The macula densa is going to release renin. The renin is going to act on the angiotensin to convert angiotensin 1 to angiotensin 2. And angiotensin 2 is important to produce aldosterone. Another mechanism is that whenever there's hyperkalemia is very deadly and very fatal, especially to the heart. So whenever the body senses that there is increased potassium in our body, this directly stimulates zona glomerulosa to produce aldosterone in order to decrease potassium and lead to potassium excretion. Also, low sodium levels, hyponatremia, leads to the production of aldosterone in order to reabsorb sodium. And we said that there is a minor role of ACTH. We mentioned that ACTH helps in the first step of aldosterone synthesis by converting the cholesterol to pregnenolone by the SCC enzyme. These are four conditions in which aldosterone secretion increases. What about inhibition? We have the atrial natriuretic peptide, or ANP. Basically, what happens is that whenever there is high pressure or high volume in the atria or stretch of the atria, this would lead to the production of ANP. And ANP inhibits the production of aldosterone because we already have enough blood pressure, we already have enough blood volume. There's no need to reabsorb more salt and reabsorb more fluid. So that's why the ANP inhibits the activity of the zona granulosa and inhibits the secretion of aldosterone. We have some additional factors that affect the HPA axis. We mentioned stress. This stress or the fight flight response could be neurogenic or it could be systemic. For example, if you are in fear, constant fear, or chronic stress, this would lead to the activation of the HPA axis, as well as infection itself is a stress to the body, or trauma. These are very stressful to the body. So all of these increase the CRH as well as the ACTH, leading to the production of more cortisol. One thing to note is that cortisol, since it's hydrophobic or lipophilic, it needs to be bound to proteins. So 90% of these proteins are bound to CBG or transcortin, and 5 to 7% are bound to albumin. And only the free part of cortisol is the biologically active. And this is what we measure in labs, like in salivary cortisol. Regarding the metabolism, the cortisol is inactivated by the liver. It's metabolized through glucuronide and as well as sulfate conjugation. And the circulating half-life of it is around 70 minutes. Okay, let's talk about some diseases of the adrenal cortex. We have the Cushing syndrome or Cushing disease. So what happens is basically there is an increased cortisol in our body. And this could be due to four main reasons. It could be due to exogenous corticosteroids. We're taking corticosteroids from outside, but like in heavy amounts, a lot of corticosteroids that would lead to Cushing syndrome. And this would lead to decreased ACTH because you have enough corticosteroid in your body. So the body would sense that, okay, we have enough corticosteroids, so there's no need to produce ACTH. And this would lead to bilateral adrenal atrophy because we said that ACTH is important for the trophic or the growth effect of the adrenals. If you're taking exogenous steroids, it would affect the adrenal gland, and this would lead to bilateral adrenal atrophy. And it's actually the most common cause, and it's easily diagnosed if the patients are truthful and they said, yeah, I've been taking exogenous corticosteroids, you can diagnose it easily. But there are other ways to diagnose it. Okay, then we have another cause, which is the primary adrenal adenoma or hyperplasia or carcinoma, which is something that happens in the adrenal gland itself, in the zona fasciculata. So if there's a tumor or hyperplasia or cancer inside the adrenal gland, this would result in the production of corticosteroids or glucocorticoids a lot. Okay, and this would result in decreased ACTH secretion. Why? Because you're secreting enough corticosteroids, so there's no need to, there's a negative feedback. And what happens is that usually when there's a cancer or a tumor in the adrenal gland that produces corticosteroid, it happens in one side. So one side is going to be huge, and the other adrenal gland would be small because there's decreased ACTH. This decreased ACTH would lead to the atrophy or the shrinkage of the other adrenal gland that is normal. We have an ACTH as a third cause. We have an ACTH secreting pituitary adenoma, which is a tumor in the pituitary gland that secretes ACTH. And this is called Cushing's disease. Whenever the cause of Cushing syndrome is caused by the tumor in the pituitary gland that secretes ACTH, it's called Cushing disease. Another cause is the secretion of ACTH from ectopic pregnancy, ectopic cancers or tumors. So, for example, if there's a small cell lung cancer or bronchial carcinoids, these have paraneoplastic effects. So they secrete ACTH and they would result in increased ACTH secretion. And both of these tumors, either from the pituitary or from an ectopic area, would lead to bilateral adrenal hyperplasia because of the trophic effect of the ACTH. So what would be the findings? Hypertension, obviously, because we mentioned that it upregulates the corticosteroid, upregulates the alpha-1 receptors, as well as it decreases the nitric oxide, as well as it has mineralocorticoid activity, so it would lead to more fluid retention or reabsorption, weight gain, moon feces, abdominal striae because of the poor collagen synthesis and the thinning of the skin. We have truncal obesity because what happens is that there's proteolysis in the upper limb and lower limb or the extremities. Um, and this would lead to muscle wasting, but there would be accumulation of fat in the trunk area. So there would be truncal obesity, there would be buffalo hump. Also, there would be accumulation of fat in the back, in the neck. Also, there would be skin changes like thinning, striae. There would be hirsutism. There would be osteoporosis because of the decreased osteoblast activity. There would be hyperglycemia. We mentioned that corticosteroids are diabetogenic. So there would be insulin resistance. They are more prone to developing diabetes. There would be amenorrhea because it interrupts the GnRH signaling. There would be also immunosuppression. So all of these are basically symptoms of Cushing's or increased cortisol in our body. In order to diagnose it, first, we go with a simple test. We go with a 24-hour urine-free cortisol or late-night salivary cortisol. So either we collect urine and we measure the free cortisol in the urine. If it's increased, we have a diagnosis of Cushing syndrome, or we take a late night salivary cortisol, because at late night when you're sleeping, it's supposed to be the lowest in which cortisol levels are. So if there's an increased late night cortisol levels, then you have Cushing syndrome. Now, you established that the patient has Cushing's syndrome. How would you differentiate the causes? How would you know if it's from the exogenous use or from the adrenal gland or from the pituitary or ectopic? We then move on to a low dexamethasone suppression test. So dexamethasone is basically a corticosteroid, it's cortisol. So we first give a low dose, then we measure the serum ACTH. If it's suppressed, if we found out that the ACTH levels are low, it means that it is an ACTH independent Cushing syndrome. It means that the ACTH has no role in increasing the cortisol production. Okay, and when do we see this case? Whenever there's exogenous corticosteroids, because exogenous would decrease ACTH, as well as adrenal tumors would suppress the ACTH. So what I want you to know is that first, we take the 24-hour urine-free cortisol or the late night salivary cortisol. We establish Cushing syndrome. Now we want to know the cause. We then give the low dexamethasone suppression that we give a low dose dexamethasone, and then we measure ACTH. If it's suppressed, it means that the ACTH has no role in increasing cortisol in our body. And when do we see this case? Whenever we have exogenous steroid use or there's adrenal tumor that is increasing the production of cortisol without depending on the ACTH simulation, okay? Or stimulation, sorry. So what would help you differentiate if it's exogenous or adrenal tumor? Of course, if the patient is trustful and he tells the truth, then it's easy. If not, you go with CT in order to find if there's an adrenal tumor. Okay, and this is ACTH independent Cushing syndrome. In case the ACTH is still high, it means that the ACTH has role in increasing cortisol. So when do we see this? Whenever there's pituitary adenoma that keeps on secreting ACTH, or there is an ectopic tumor that keeps on secreting ACTH. How do we differentiate? Then we move on to a high dose dexamethasone suppression test in order to differentiate. If it gets suppressed, it means it's part of the HPA axis. It's a tumor, but it behaves when you stress on it. When you give it a high dexamethasone suppressed test, it gets suppressed. So if it's part of the HPA axis, it means it's a Cushing disease, or it's a tumor in the pituitary. Okay, so after you establish that it is elevated, the ACTH is elevated, how would you proceed? So it's ACTH dependent, in which there is a role in which the ACTH increases the cortisol. How would differentiate if it's ectopic or pituitary adenoma? You give a high dose dexamethasone suppression test. If it's suppressed, it means it follows the HPA axis. It means that it is Cushing disease. It means that there is a pituitary adenoma that's secreting ACTH and stimulating the adrenal glands to produce cortisol. Okay. So what would you proceed with? You would proceed with MRI of the pituitary to identify the adenoma. If it's not suppressed, it means that this is an ectopic tumor that does not listen to the HPA axis. It keeps on producing ACTH. يعني whatever you do, it's gonna still produce ACTH. So what would you do? You go to with CT of the chest and abdomen pelvis to identify the tumor, if it's in the lungs, if it's in the abdomen, or etc. There's also a CRH stimulation test. If you give CRH and ACTH increases, because CRH acts on the pituitary. If it increases, if the ACTH increases, it means it's Cushing's disease. If it does not increase, because CRH is not going to stimulate the ectopic tumor. So if it does not increase the ACTH, it means this is an ectopic ACTH secretion. Okay, this is very important. It's high yield. I know I took a lot of time, but when I was first year or second year, I didn't understand that well. I hope you guys understood it. Okay, then moving on to another disease, which is adrenal insufficiency or Addison disease. Basically, what happens is that it could be divided into primary adrenal insufficiency, secondary, or tertiary. Primary adrenal insufficiency means there is a problem in the adrenal gland itself. The adrenal gland is not producing the hormones. So there would be deficiency of aldosterone as well as cortisol due to the loss of the gland function. So if there's no aldosterone as well as cortisol, you know what would happen. There would be hypotension, there would be hyperkalemia, there would be metabolic acidosis, as well as there would be hyperpigmentation, because since you're not producing aldosterone and cortisol, there would be the loss of negative feedback. There would be increased ACTH production. And with ACTH production, there would be increased MSH, and this would lead to hyperpigmentation. It could be acute or chronic. Acute happens when there's hemorrhage. Chronic, when it's chronic, it happens throughout a long period of time. It's called Addison disease. And what happens is usually there's adrenal gland atrophy due to the destruction of this gland. In the Western world, it's autoimmune. In the developing world, it's due to TB. Okay, this is the primary. Secondary, it means uh, in the upper center, it means the pituitary itself is not producing ACTH. So there's decreased uh, secretion of ACTH, and this would lead to decreased production of adrenal hormones, the corticosteroids, as well as mineralocorticoids, as well as androgens. So what would happen? There would be no skin pigmentation, okay, because you're not producing ACTH, you're not producing MSH. There is no pigmentation. There would be no hyperkalemia, because we mentioned that aldosterone synthesis is still happening because it's mainly controlled by the RAS system. So there would be no hyperkalemia. Okay. In terms of tertiary adrenal insufficiency, it happens with chronic exogenous use. So when you use exogenous steroids, you one by one, step by step, you lead to the atrophy of the adrenal gland. And when you stop it suddenly, you stop using the exogenous corticosteroids suddenly, this would lead to abrupted withdrawal, and the gland won't be able to produce the hormones. So in order to prevent this, you usually taper it down. Whenever a doctor prescribes corticosteroids or like steroids, they tell the patient on whenever they want to stop, they taper it down in order to give time for the adrenal gland to regenerate back and to regain its function. Okay. Then we have the opposite. We have hyperaldosteronism or Con syndrome. So what happens in hyperaldosteronism is that there's increased production of aldosterone from the adrenal gland. And you know what are the signs of hyperaldosteronism? This includes hypertension because of water retention and reabsorption. This would lead to decreased or normal potassium, because with exaggerated aldosterone effect, this would lead to hypokalemia. This would lead also to metabolic alkalosis. And it could be divided into primary hyperaldosteronism and secondary. Primary, it means this is a problem in the adrenal gland. There's a tumor that arises from the zona glomerulosa, and it is also called Con syndrome. And this would lead to the production of more aldosterone and decreased secretion of renin. Okay. Secondary, it means it's not included to, it's not caused by the adrenal gland itself. There are external factors like, for example, a tumor that produces renin. This would keep acting on the adrenal gland to produce aldosterone. Okay. Now moving on to the adrenal medulla. Adrenal medulla is basically, as we mentioned, a modified sympathetic ganglion. Um, so it's related to the sympathetic system, fight or flight response. It is made up of chromaffin cells that secrete catecholamines, mainly epinephrine, 80%, and norepinephrine, 20%. So what happens is that you have the sympathetic activation from the spinal cord. The preganglionic sympathetic neurons are going to get activated when there's a fight or flight response. This preganglionic sympathetic neurons are going to release acetylcholine. Okay. This acetylcholine acts on chromaffin cells, and these chromaffin cells are postganglionic modified sympathetic fibers. These chromaffin cells will release catecholamines, and these catecholamines, norepinephrine and epinephrine, are going to act on adrenergic receptors. Okay, what is the main function of the adrenal medulla? Is to mediate the fight or flight response. So, how are these catecholamines made up? They are made up from amino acid tyrosine, okay, in the chromaffin cells of the adrenal medulla. How is this synthesis happen? Basically, tyrosine is converted to L-DOPA, then L-DOPA dopamine. Dopamine is then converted to norepinephrine, and then finally norepinephrine is then converted to epinephrine. One thing to notice is that the rate limiting step of the synthesis of catecholamines is the tyrosine conversion to L-DOPA, and this is done by the tyrosine hydroxylase. Another thing that we mentioned before, that glucocorticoids have important function on the adrenal medulla secretion, and it modulates the production of catecholamines. So what happens is that glucocorticoids from the adrenal cortex stimulate the PNMT, and this PNMT converts norepinephrine to epinephrine. So not only glucocorticoids, they stimulate the release of catecholamines, they also help in converting norepinephrine to epinephrine by acting on the PNMT enzyme. Okay. So after you produce the catecholamines and you want to metabolize them, what happens is that these catecholamines are degraded by two main enzymes. We have the MAO and the COMT, the monoamine oxidase, as well as the catechol methyltransferase, the COMT. The final metabolites would be the epinephrine, norepinephrine converted to vanillamandelic acid, which is VMA, and dopamine is converted to homovanillic acid, or HVA. One thing to notice is that the adrenal medulla also produces dopamine, but very little amount. It's not significant. What I want you to focus is the epinephrine, norepinephrine. The end metabolites are the VMA, and these metabolites are excreted in urine. Why is it clinically important? Because there's a condition in which there's a tumor of the adrenal medulla or the chromaffin cells, in which there's excess production of catecholamines, and if these catecholamines are produced excessively, there would be a lot of metabolism, and you would find elevated levels of VMA in the urine. But we're gonna talk about it more in a few slides. Just when we want to touch upon the adrenergic receptors, after the catecholamines are released, they bind to adrenergic receptors. We have alpha receptors as well as beta receptors. Alpha receptors, there are alpha 1, alpha 2. Alpha 1, they are located in the vascular smooth muscle, as well as the pupillary dilator muscle, as well as the pilomotor muscle. So what are the effects? When they bind to the vascular smooth muscle, they cause vasoconstriction. So they bind on the arteries or the arterioles. The catecholamines, they bind on the alpha 1 receptors of the arterioles, and this would lead to vasoconstriction as well as to increased blood pressure. They also act on the pupillary dilator muscle in order to cause pupil dilation. And this is important because you want to dilate your pupils in order to stay aware and cautious in flight or flight response. As well as it acts on the pilomotor muscle to cause piloerection or goosebumps. The alpha 2 receptors are located in the presynaptic nerve terminals, or also pancreas, as well as the platelets. What are the effects? They basically inhibit the production of norepinephrine release. This is a negative feedback. Whenever the cell body senses that there is increased production of norepinephrine, it wants to stop down or push the brakes. So basically, some epinephrine binds to the presynaptic alpha 2 receptors in order to inhibit or calm down the production of norepinephrine. It also decreases insulin secretion because you need to raise up the glucose. So it would lead to decreased insulin secretion as well as platelet aggregation. Regarding the beta receptors, we have three beta receptors. We have the beta one. You have one heart, so mainly it acts on the heart, the SA node and the AV node and the ventricles. So what would be the effects? It would be increased heart rate, contractility, cardiac conduction, renin secretion, as well as lipolysis. All of these are important whenever you have a flight or flight response. Then the beta 2 receptors, you have two lungs. So the location is lungs, liver, skeletal muscles, uterus, GI tract. What are the effects? Bronchodilation, because you need to breathe more oxygen. Vasodilation in skeletal muscles. Although alpha 1 causes vasoconstriction, but beta 2 causes vasodilation in skeletal muscles because your muscles are important whenever you have fight or flight response. You need them. So vasodilation in order to bring more nutrients to the skeletal muscles. Relaxation of the uterine and GI smooth muscle because you don't want to digest right now. You're more focused on the fight or flight response. Increased glycogenolysis, you want to break down glycogen to glucose. Increased glucagon secretion because glucagon would raise the blood sugar levels. Okay, so beta 3 receptors are located in the adipose tissue, and the effects, it basically increases lipolysis, breakdown of fat, in order to be used for energy, and also it increase the thermogenesis in brown fat, especially in children, in young babies. Um, so overall effects, they basically play a role on the carbohydrate metabolism. So catecholamines basically they increase the breakdown of glycogen, increase the production of glucose, and they decrease the breakdown of glucose because you need this glucose. As an effect, this would lead to the increased glucose release from the liver, done by the gluconeogenesis. There would be decreased glucose utilization in the muscle because you want to raise the blood sugar levels, and the epinephrine would inhibit the insulin secretion as well as would stimulate glucose secretion. So the result would be increased blood sugar. Okay, on the lipids, they would stimulate the breakdown of triglycerides and adipose in order to be used for energy. It would increase free fatty acids in the circulation, and the free fatty acids are used as a source of energy by the heart as well as the skeletal muscles. Okay, cardiovascular effects increases cardiac output, increases blood pressure, increases oxygen consumption. For the smooth muscle effects, it causes bronchodilation. It relaxes the GI smooth muscle. It causes vasodilation in skeletal muscle vessels. And these responses help prepare the body for rapid physical activity during stress. One thing to note, the clinical relevance of epinephrine or EpiPen is that it is used in anaphylactic shock. In anaphylactic shock, there is vasodilation. So in order to bring back the vasoconstriction, you give EpiPen. This would act on the alpha 1 to cause vasoconstriction and increase peripheral resistance. Also, in case of anaphylactic shock, you cannot breathe well. So also the epinephrine is going to act on the beta 2 on the lungs to cause bronchodilation. In cases of severe hypoglycemia, we give also EpiPen because this would block the insulin as well as stimulate glucagon, as well as stimulate gluconeogenesis, stimulate glycogenolysis, and decrease glycolysis. All right. Now, moving on to pheochromocytoma, which is basically a neuroendocrine tumor that arises from the chromaffin cells. These chromaffin cells would produce excessive catecholamines. So, where do they happen? Mainly, it arises from the chromaffin cells of the adrenal medulla, but sometimes it can occur along the paravertebral sympathetic chain from the pelvis towards the base of the skull. But 95% it occurs in the abdomen, 90% it arises in the adrenal medulla, and about 80% it's on one side. It affects one of the adrenals. So what would happen is that there's a tumor of chromaffin cells. Chromaffin cells would secrete more epinephrine and norepinephrine. And what is clinically important is one of the main causes of secondary hypertension. And whenever you treat this tumor or resect this tumor or remove this tumor, the hypertension gets corrected back. Okay. Just a recap, it's the most common tumor of the adrenal medulla in adults. It's derived from the chromaffin cells. Chromaffin cells are arose from neural crust cells, which is an ectodermal. Rule of 10, 10% is malignant. It means that 90% is benign, 10% is bilateral, so 90% is on one side, and 90% it's extra adrenal. Um, sorry, 90% is in the adrenal, 10% it calcifies, and 10% it happens in kids. And this happens, or the symptoms happens because of the secretion of epinephrine, norepinephrine, and dopamine. So what would be the symptoms? You have the five Ps. We have increased blood pressure, you have pain, headache pain because of the increased pressure in the skull, as well as perspiration, which is sweating, as well as palpitations because of the epinephrine acting on the heart, as well as pallor because of the systemic vasoconstriction. So these are episodic, they're not constant. Whenever the tumor secretes or excretes the epinephrine and norepinephrine into the bloodstream, these episodes happen. Um, so how can you diagnose it? We basically find increased catecholamines and catecholamine metabolites in the plasma, and also you would find increased VMA in the urine. Then once you diagnose this, you go with CT to locate the tumor in the adrenal medulla. For the treatment, you don't have to know it, but usually we go with alpha blockers first, then we go with beta blockers because you want to prevent a hypertensive crisis. If you block the beta receptors first, then the epinephrine, norepinephrine is going to act on the alpha receptors, and this would lead to a hypertensive crisis and lead to severe vasoconstriction of the vessels or the vasculature in our body. And in order to avoid this, you go first with alpha blockers, then beta blockers. And also phenoxybenzamine is used to treat pheochromocytoma. But you don't have to know all of these, just like for your knowledge. And that covers the adrenal part. Then we're gonna move on to the endocrine pancreas. Alrighty. So the pancreas has two main functions, exocrine functions as well as endocrine functions. The exocrine is made up of acinae that produce digestive pancreatic juices in order to help with digestion. We don't want to talk about this. What we are focusing on is the endocrine part of the pancreas, which is composed of the islets of Langerhans. And the function of these cells or these endocrine portions is to secrete insulin as well as glucagon. There are like 1 to 2 million islets of Langerhans present in the pancreas, and they contain cells that produce insulin, glucagon, as well as somatostatin. Okay, so let's have a look on the histology of the pancreas. As you can see, here is the exocrine part, which is composed of acinae that secretes pancreatic juices. Then you have the endocrine part of the pancreas, which are basically islets of Langerhans. And these islets of Langerhans contain cells that produce insulin, glucagon, as well as somatostatin. So what are the cells of the endocrine pancreas? We have the alpha cells, which contributes to 20 to 30% of the cells in the islets of the Langerhans. And the main function of alpha cells is glucagon production. So a way to remember is there is alpha A here and gluca, there's A also. So alpha cells produce glucagon. And where are they found? They are found at the periphery of the islets of the Langerhans. Then we have the beta cells, which constitutes to up to 60 to 80%. The function of beta cells is the production of insulin. And since insulin is very valuable, you could find the beta cells in the center of the islets of the Langerhans. Then finally, we have the delta cells, which secrete somatostatin, and they contribute up to 8% of the cells. They are found interspersed between the alpha and the beta cells. Okay, okay, okay. So I showed you this pic, and these are the islets of Langerhans. It contains the alpha, beta, and delta, but is there a way to differentiate between these cells because they all look similar? So a way to differentiate between these cells is using a stain called the Mallory-Azan stain, and this helps us differentiate these cells based on their color. So for alpha cells, which are the cells that are located at the periphery, which are the cells that produce glucagon, When stained using the Maillard stain, they stain red. So a way to remember alpha, there's A ahmar, so ahmar color, red color. So the alpha cells which produce glucagon at the periphery are stained red. Then we have the beta cells. The beta cells are the cells responsible for producing insulin. They are more in the center because they are more valuable, they are more important. So they are stained brownish orange. So B, beta cells, brownish orange. Okay. Then finally, we have the delta cells, which are interspersed between the alpha and beta cells. And you can see that it is stained in blue color. Okay. So, how are these cells interacting and how are these cells regulated? First, we have the delta cells, which produce somatostatin, and you know that somatostatin it has an inhibitory effect. So it's going to act on beta cells to inhibit or to modulate, as well as it's going to act on the alpha cells also to inhibit the production of glucagon, and it would inhibit the production of insulin as well. For beta cells, you know it's important in producing insulin. So what makes the beta cells active? There are some GIT hormones that increase the stimulation of beta cells, as well as glucose. Glucose is one of the main factors that stimulate insulin production because when blood glucose levels rise, you need to bring it down and regulate it. So beta cells are stimulated when there is glucose in the blood. Also, the parasympathetic innervation, the vagus nerve, you know, rest and digest. Whenever you eat, there is stimulation of the beta cells to produce insulin, as well as amino acids produce or stimulate beta cells to produce insulin. Then we also have the sympathetic nervous system. Whenever you're in fight or flight, you want to raise the blood glucose, not to lower it. So the sympathetic nervous system is gonna inhibit beta cells from producing insulin. Other side, you have the alpha cells that produce glucagon. You can see that glucose inhibits alpha cells because if you have already enough glucose, then why do you need to raise the blood glucose levels, right? So the glucose inhibits alpha cells. What stimulates alpha cells is amino acids. Some amino acids stimulate alpha cells to produce glucagon, as well as the sympathetic nervous system. You know, when there's stress, when there's physical activity, you need to stimulate the glucagon or the alpha cells to produce glucagon in order to raise up the blood glucose. So exercise, fasting, sympathetic activity, amino acids, they stimulate alpha cells. Not only that, but alpha cells actually stimulate beta cells because you this is a protective effect because you don't want to raise the blood glucose levels that much. You also want to regulate it. And in order to have a balance between increasing blood glucose and lowering down blood glucose, the alpha cells stimulate beta cells in order to produce insulin so that the blood glucose levels do not rise that much. Okay. But on the contrary, the beta cells, they inhibit alpha cells. So it's a kind of a selfish act by beta cells. All right. I think that's all. Yeah. Okay. So let's talk more about insulin. So insulin is basically derived from proinsulin. It's a polypeptide protein. So insulin is basically derived from proinsulin. What is proinsulin? Proinsulin is basically made up of the A chain as well as the B chain as well as the connecting peptide or the C chain. So A chain, then the C peptide that connects the A chain with the B chain. Not only this, but there's also disulfide bridge between the A chain, two disulfide bonds, as well as there is a disulfide bond inside the A chain connecting two amino acids. So insulin is derived from proinsulin, and the proinsulin is composed of A chain, B chain, and the C peptide. It is made up of 31 amino acids, and you can see the two disulfide bridges that connects the A chain to the B chain. And these are important for its biological activity. Okay, so what happens next? When we need insulin, the proinsulin gets converted to insulin. How? By the cleavage of the C chain. So whenever the C chain is cleaved, The proinsulin gets converted to the insulin and it becomes the active biological molecule. But the insulin is then stored in secretory granules alongside with the C-peptide. And this is important because there is an equimolar, the C-peptide is secreted in an equimolar amount with insulin. So whenever insulin increases, C-peptide increases because they are both excreted together and they are both stored in the same secretory granule. And C-peptide doesn't have a biological activity, but it is used clinically to differentiate the it's used as a marker to look for endogenous insulin secretion, as well as to differentiate between different conditions in which insulin is high, C-peptide is low, and we're gonna discuss this. And how is it measured? It is measured in blood or urine to assess the pancreatic beta cell function. So, what is the role of C-peptide? It helps differentiate different conditions that are happening in our body. For example, in insulinoma, it's a tumor in the beta cells. So there is a continuous production of insulin. And with insulin, there's also production of C-peptide because this is an endogenous. This is insulin that is produced by our body. And whenever our body produces insulin, it would produce also C-peptide with it. So what happens in insulinoma, there's an autonomous, you cannot control it. It keeps on producing autonomous B cell insulin secretion. And this would lead to the increased C-peptide as well as insulin. If it's exogenous insulin, when you take exogenous insulin, you don't have the C-peptide, it's pure insulin. So if there is a huge amount of insulin that you took and you want to decide if it's endogenous or exogenous, you measure the C-peptide because if it's exogenous, the C-peptide is going to be decreased or not available, while the insulin is going to be increased. In diabetes type 1, because there is no insulin at all, so both would be decreased because the beta cells are not producing insulin. So if they're not producing insulin, they're not going to produce C-peptide. In diabetes type 2, there is insulin, but there is insulin resistance. So still, C-peptide is going to be normal or increased, as well as the insulin is going to be normal or increased. They're going to be complementary. But in chronic kidney disease, because C-peptide is excreted through urine and filtered through the kidney, if the kidney is not functioning well, the insulin could be excreted normally and metabolized, but the C-peptide wouldn't be able to get excreted through urine. So what would happen in chronic kidney disease is that there would be increased C-peptide in the blood or the urine. Sorry, in the blood, yeah, not in the urine. And there would be normal insulin in our body. And this is due to the reduced renal clearance of the C-peptide, leading to accumulation in our body. One of the medications used in diabetes is sulfonylureas, and this basically stimulates the production of insulin. So if you want to check the C-peptide and insulin, this medication stimulates the endogenous secretion of insulin. So when there's insulin secretion, there's also C-peptide secretion. Okay? Okay, so how is insulin secreted when it's produced inside the beta cell? So after eating a meal, what would happen? The blood glucose levels would rise, right? So this blood glucose level is proportional to the amount of glucose surrounding the pancreatic beta cells. So if there's a high blood glucose level in the blood, it means there's high concentration of glucose around the beta cells. What happens is that the glucose enters these beta cells through GLUT2 transporters by facilitated diffusion. Basically, because the glucose is highly concentrated outside, it just diffuses through the GLUT2 transporter. Okay? What happens is that this glucose is then phosphorylated by glucokinase, and this changes glucose into glucose 6-phosphate, which is the rate limiting step. And through several reactions, the glucose is going to be metabolized to ATP, and the ATP is going to increase and increase and increase. So with this, the ATP ratio, the ATP to ADP ratio would increase. By having this ATP, this increased ATP is going to act on the ATP sensitive potassium channels, and it would close this channel. And you know that potassium is more concentrated inside the cell and it likes to exit outside the cell. So if you close this channel, the potassium wouldn't be able to leave the cell. And since potassium is a positive ion, so it would lead to the depolarization, or it would bring the membrane potential to the positive side. And what happens with depolarization? There would be stimulation of the voltage gated calcium channels. So the voltage gated calcium channels would open, and the calcium channels and the calcium would influx throughout the beta cells. And what does the calcium do? Basically, the intracellular calcium, it triggers the exocytosis of the insulin containing secretory granules. So this calcium would bring the secretory granules to the membrane, and it would facilitate the exocytosis of insulin. Okay, to recap, what happens when blood glucose levels rise? It gets concentrated also around the beta cells. So glucose enters through GLUT2 through facilitated diffusion. Glucose is then converted to glucose 6-phosphate using glucokinase, and enters through the glycolysis pathway. This would lead to the production of ATP, and the ATP ratio to ADP would increase. This ATP is gonna act on the ATP sensitive potassium channel. Potassium wouldn't be able to leave. This would make the cell more positive, or would depolarize the cell. With depolarization, the voltage gated calcium channels would open, and then the intracellular calcium would facilitate the exocytosis of insulin granules, and insulin would be released. And this is also the same thing that the glucose enters, but then glucose gets converted through glycolysis and generates ATP. This ATP closes the potassium channels. This would lead to depolarization, opening of the calcium channels. This would lead to the intracellular calcium being high, and this would facilitate the exocytosis of insulin. All right. So now we have insulin in our body. How would insulin act on the tissues? So the insulin mainly acts on skeletal muscles, cardiac muscles, adipose tissue, as well as liver. And the insulin receptor is basically a tyrosine kinase receptor. So it is made up of two alpha units as well as two beta subunits. And it is basically a plasma membrane receptor. What happens is that the insulin binds to the alpha subunits, and this stimulates or activates the beta subunits. By doing this, this would lead to the autophosphorylation of the insulin receptor substrates, or the IRS. So let's recap. Insulin would bind to the alpha subunit. This would activate the beta subunit, and the beta subunit is gonna cause autophosphorylation of the IRS, or the insulin receptor substrates. After that, there would be activation of intracellular signaling pathways. What would be the effect? Basically, one of the effects is that the GLUT4 transporters, there would be translocation of those transporters to the cell membrane, and this would facilitate glucose to enter throughout the cell. What other effects? This would lead also to the cellular uptake of amino acids, as well as potassium, phosphate, and magnesium. And long-term effects is going to also affect the gene transcription and protein synthesis and cell growth. All right. So just to recap, insulin is secreted. It binds to the alpha subunit, and this activates the beta subunit. Beta subunit then causes autophosphorylation of the insulin receptor substrates, and these cause signaling pathways. It causes the translocation of GLUT4 receptors on the plasma membrane in order for glucose to be uptaken by the cell, especially the skeletal muscles, as well as the adipose. Then it also takes up amino acids, potassium, magnesium, phosphate. Not only this, but it also facilitates protein synthesis. It's an anabolic protein. So it would lead to protein synthesis, fat synthesis, as well as glucose synthesis, as well as growth and gene expression and transcription. Okay? So what are the effects of insulin on carbohydrates? We said that the insulin want to decrease the blood sugar. So what would happen is that there would be increased glucose uptake in skeletal muscles, cardiac muscles, and adipose tissue via the GLUT4 receptors or transporters. It would also decrease the hepatic glucose output, because you don't want to raise the blood glucose levels. It would facilitate glycogen synthesis. You want to store the glucose, excess glucose. It would also decrease the glycogen breakdown, because you don't want to raise the blood glucose levels. It would also decrease the gluconeogenesis. You don't want to produce more glucose. There's already glucose. You want to store it. And it would increase glycolysis because it wants to decrease the glucose in the blood. And also, it would increase the conversion of glucose to fatty acids as well as the alpha glycerophosphate. And this is used for triglyceride synthesis or fat synthesis. One thing to notice is that some cells in our body, they don't depend on insulin. They just take glucose whenever they are available, whenever glucose is available. Things like cells like brain, it uses GLUT1 as well as GLUT3. The RBCs, they use GLUT1. The kidney tubules, they use GLUT1, GLUT2. Intestinal mucosa, GLUT2. Liver and pancreatic beta cells, they use GLUT2. So all of these cells, they have different transporters that can uptake glucose without the need for insulin. Okay. So what are the effects of insulin on protein and lipid metabolism? We said it is insulin is a anabolic protein or anabolic hormone. So it would lead to the increased uptake of amino acids, and this increased uptake of amino acid would lead to the production of protein or protein synthesis, and there would be decreased proteolysis because it acts as a protein sparing effect. You want to build, you don't want to break. Okay. For the lipid metabolism, it's anti-lipolytic. It does not want to break down lipids. In order to do this, it would decrease the activity of the hormone sensitive lipase. Lipase, it means it wants to break the lipids, so it would decrease this activity. And also, it would decrease the lipolysis as well as the fat mobilization. Okay. And on the other hand, it would induce lipogenesis. So it would increase the lipid formation as well as triglyceride storage through the VLDL as well as adipose tissue. And one thing that is really important, that insulin is anti-ketogenic. So it decreases the ketone body formation or ketone body production, and it increases the peripheral use of keto acids. So what happens in diabetes type 1, we're going to talk about it, is that you don't have this protective effect of insulin. So what happens is that there would be unopposed action of the glucagon. And, I'm going to discuss later on that glucagon simulates ketogenesis and increases the ketone bodies. So since type 1 patients who have diabetes, they don't have the protective effect of the insulin, they are more prone to diabetic ketoacidosis. And we're going to discuss it more. Just have it in your mind. Okay. So what are the effects, insulin effects on hepatocytes or the liver? So what happens is that the liver is a major source for glycogen synthesis and storage. So it would increase the glycogen synthesis, sorry, by activating enzymes like glucokinase and glycogen synthase. It would also increase glycolysis because you want to decrease the blood sugar levels. This is done by the activation of phosphofructokinase as well as the pyruvate kinase. It would also increase the lipogenesis, fat production, by the activation of acetyl-CoA carboxylase as well as the fatty acid synthase, as well as it's gonna increase the protein synthesis and decrease the production of glucose through inhibition of the glucose 6 phosphatase. Okay. Insulin effects on muscle and adipose, it's similar. Muscle cells, basically, there would be an increased glucose uptake by the GLUT4. There would be increased glycogen synthesis. You want to store this glucose. There would be increased glycolysis, and there would be more protein synthesis and decreased protein breakdown. Okay. For adipocytes, it's also the same. There's increased glucose uptake. There's increased glycolysis in order to form the alpha glycerol phosphate formation for different pathways. There would be increased fatty acid synthesis, as well as there would be decreased hormone sensitive lipase. So as an effect, there would be decreased lipolysis. There would be decreased breakdown of lipids. And there would be increased lipoprotein lipase. And this mainly helps in uptake of fatty acids from chylomicrons and VLDL and storing them in adipocytes. Okay. So this is basically what I said as a summary. I hope you guys understood the metabolic effects of insulin. Not only this, not only does insulin affect the metabolism, it also affects the growth. It has growth effects because it's anabolic. So in some tissues, it promotes growth, and this is done by protein synthesis, by increasing protein synthesis, and it has several mechanisms. One of the mechanisms is that it stimulates the production of growth factors like the insulin growth factor 1, and you know how much important insulin growth factor 1 is for growth and organ development and organ growth. It also promotes synthesis of macromolecules in cartilage and bone. It regulates transcription and mitogenic factors. It enhances cell growth and differentiation as well as proliferation. And one of the cool things is that insulin works with growth hormone for more growth, but each has different functions. The insulin promotes cellular uptake of amino acids, and growth hormone promotes the after uptaking amino acids, the transcription, translation, and production of protein. So, what is the clinical significance in terms of growth done by the insulin, especially in the fetus when there's insulin deficiency or resistance in the fetal life? The fetus won't be able to grow easily, and at birth, he would be born with a low birth weight. And postnatally, if, for example, a patient has type 1 diabetes, the insulin growth effects won't be available. So the patient would have a wasting of lean body mass. On the opposite side, if there's increased exposure of insulin during fetal life, this would lead to excess growth of the baby, and during birth, the baby would be born with fetal macrosomia, or it would be the baby would be very big because of the anabolic effects of insulin. What are the other physiological effects? We mentioned few. We said that it regulates electrolyte balance. So it helps in uptaking potassium, magnesium, phosphate by muscle and liver, and this decreases serum levels. So it has a protective function, especially the potassium, because when it rises, it leads to arrhythmias and a lot of complications. It also increases the renal sodium reabsorption. So it has an anti-natriuretic effect. If you don't have this insulin, there would be more excretion of the sodium, and there would be polyuria. We're gonna talk about it later. What other effects? We have vascular effects. So what does the insulin do? It basically causes vasodilation in the skeletal muscle and adipose tissue using nitric oxide. So it increases nitric oxide synthesis the areas around skeletal muscle and adipose, and this helps more nutrients and more sugar, more amino acids to go to that areas and get uptaken by the skeletal muscles as well as the adipose tissue. Okay, and also it has a function on appetite regulation. So insulin inhibits the release of neuropeptide Y in the hypothalamus, and this would stimulate fullness, or would make you would reduce appetite for people. So we're done with insulin. Moving on to the opposite side, glucagon. It's also a peptide hormone, but it's made up of 29 amino acids, which this hormone is secreted by alpha cells in the pancreatic islets of Langerhans. So how is it synthesized? It's synthesized from pre-pro glucagon, then it goes to pro-glucagon, then it goes to glucagon, and this glucagon is then stored in secretory granules. Structurally, it's similar to some GI hormones such as secretin and GIP. What I want you to know is that glucagon mainly the target organ acts on the liver, and on the liver there are G protein coupled receptors. This would lead to the activation of adenylyl cyclase, and this would lead to the increased cyclic AMP signaling. Regarding the regulation of secretion, what stimulates glucagon secretion? Whenever you need blood glucose. So in cases of hypoglycemia, there's decreased blood sugar, so you need to raise up this blood glucose. So this stimulates glucagon release. Amino acids, also the fight or flight response, sympathetic activity, fasting, exercise, all of these conditions, you need more blood glucose in your body. So glucagon gets released. What inhibits glucagon is glucose, because if you have enough glucose, then there's no need to raise the blood glucose levels. Also insulin, because it's selfish, as you remember. Insulin inhibits glucagon, and somatostatin, which is an inhibitory hormone that inhibits not only glucagon but also insulin. What is the main role? As we said, it maintains the blood glucose, especially during fasting and exercise, sympathetic activity. And this is done by increasing hepatic glucose production. This is the main function, acting on the liver. So, what are the effects of carbohydrates? It's opposite. Generally, it opposes the action of insulin and it acts as the fasting starvation hormone. So, what would be the effects on glucose metabolism? You need to raise the blood glucose. So, how is it achieved? By increasing glycogenolysis. So, you want to break down the glycogen in the liver in order to raise up the blood glucose. You want to produce more glucose by gluconeogenesis in the liver. You want to decrease glycolysis because you want to have sufficient glucose in the body. So what would be the overall result is increasing blood glucose. So it has a hyperglycemic effect. And hyperglycemia is achieved not because of the reduced peripheral glucose utilization. The peripheral cells can still use glucose, but hyperglycemia or the raise of the blood glucose is achieved by the increased hepatic glucose production. So the main action is on the liver by increasing glycogenolysis, by increasing gluconeogenesis, by decreasing glycolysis. So the liver plays a major role when glucagon acts on it. So what are the effects of protein and lipid metabolism? So lipid metabolism, it's opposite to what insulin did. You want to break the fat in order to release free fatty acids and glycerol. You want to stimulate the beta oxidation of these fatty acids in the liver. You would find ketogenesis, and this is what contributes to metabolic acidosis, especially in DKA, diabetic acidosis in type 1, because there's no insulin, there's no this protective effect of insulin is not found, then you have the unopposed glucagon secretion, and this glucagon would stimulate ketogenesis. Okay, regarding the protein, overall, there's a net proteolytic effect. The body just wants to break down. Glucagon is basically a catabolic hormone. It wants to break down, break down, break down, break down. So what would happen? There would be an increased release of gluconeogenic amino acids. The body wants to break down gluconeogenic amino acids or proteins in order for these to get used or get taken up by the liver, and these amino acids, gluconeogenic amino acids, would then be oxidized and would enter the urea cycle, and urea would be produced, as well as these amino acids would go through gluconeogenesis to produce glucose. So the overall effect is glucose sparing by using fats and amino acids as the energy sources. Okay, what are the effects on hepatocytes? We said that the glucagon, sorry, primarily acts on the liver. So regarding the carbohydrate metabolism, it's gonna increase the breakdown of glycogenolysis. And this is done by the activation of glycogen phosphorylase. Phosphorylase, it means it breaks down the glycogen. And also it decreases glycogen synthesis. You don't want to store. Now, this is done by insulin. You want to break, not to synthesize. Also, regarding the gluconeogenesis or the production of glucose, it increases the expression of some enzymes to facilitate the production of glucose through gluconeogenesis. It increases the expression of PepCK, fructose 1 biphosphatase, as well as glucose 6 phosphatase. And for the fat metabolism, it also decreases fatty acid synthesis and increases the beta oxidation of fatty acids. So the net effect is there would be increased hepatic glucose production and energy availability during fasting. Okay, and this is basically covers what I said, the effects of insulin as well as glucagon. Go over it real quick. Inshallah, I've made it easier for you guys. So moving on to the other part. Why is this glucose essential? Like, can we survive without glucose? Unfortunately, not. Glucose is important because it is the main energy source for tissues like the brain, the retina, the germinal epithelium of the gonads. So without glucose, the brain cannot survive. The retina cannot function. The germinal epithelium of the gonads cannot do their job. So there has to be there has to be enough glucose in the body in order for these tissues to survive. But there has to be always a balance between um, insulin and glucagon because you need to maintain the blood glucose. Whenever it's low, it's not good. Whenever it's high, it's not good. So why should hyperglycemia must be avoided? Because in case of high blood sugar levels, you know that sugar has an osmotic pressure. It's very high in osmolality. So this would lead to an increased extracellular fluid osmotic pressure. And what would happen is that fluid from the cells would get shifted from the cells to the extracellular fluid. So this would lead to cellular dehydration. Not only this, but excess sugar is going to be lost through urine. So there would be glucosuria or loss of glucose in the urine. And what happens is that whenever glucose gets lost, it absorbs fluid with it. So there would be osmotic diuresis, which means that water gets lost. And as a result, there would be volume depletion. So there would be hypovolemia. What are the long-term consequences that would affect our body if we did not maintain our blood sugar levels and we have constant hyperglycemia? We have effects like damaging blood vessels, and this would cause retinopathy, neuropathy, as well as you can see the complications of diabetes, mellitus, heart attacks, strokes, end-stage renal disease, and blindness. So it's really important to maintain the blood glucose in our body so that we satisfy the tissues that need it, and also we prevent the long-term consequences of having high blood glucose. So moving on to diabetes. So what happens in diabetes? Diabetes is basically a metabolic disorder characterized by hyperglycemia. So it's usually the diagnosis is when having a fasting plasma glucose of greater than or equal to 7 millimole per liter or 126 milligram per deciliter. What happens in diabetes? It's either caused by absolute deficiency of insulin or there is insulin resistance. So insulin is not is it's either not found, you don't have insulin, or the insulin is not functioning and there is insulin resistance. And all of this disturbance would lead to disrupted metabolism of carbohydrates, fats, and proteins. We have main types. We have type 1 and type 2. Type 1 diabetes, mellitus, is basically insulin dependent. It means that um, if you give insulin, you fix the problem because like insulin has the role. Insulin it means that insulin is the cause of the problem, or the lack of insulin is what's causing the problem, and it is usually 10 to 20% of people who have diabetes. What is it? Why is it caused? Because there is autoimmune destruction of beta cells, and we said that the beta cells are responsible for producing insulin. So if you have destruction of these beta cells, there would be lack of insulin, and this would result in absolute insulin deficiency. On the other side, you have type 2 diabetes, which is the non-insulin dependent. It means that insulin has no role in causing the hyperglycemia. بالعكس, on the other side, insulin resistance is what's causing this hyperglycemia. And it is 80 to 90% of patients who have diabetes. There's insulin resistance in target tissues, and there's relative insulin deficiency. So insulin could be normal or increased, but inadequate because there's increased insulin resistance. And here's to differentiate between type 1 and type 2. So in type 1, there's the primary defect is that there's autoimmune destruction of beta cells. The beta cells are not producing insulin. There's insulin deficiency or even absence, nothing at all. While in type 2, there's insulin resistance with relative insulin deficiency because the beta cells are still producing insulin, but with time they get burned out and they die. So at first there's enough insulin, then it becomes deficient, but the main cause or the main problem is that there's insulin resistance. The insulin is not doing its action on the receptors. What about the typical onset? Usually, type 1 is more common in or seen in childhood or adolescence, but it could be seen at any age. In type 2, it has a gradual onset and it usually happens after 40s. And nowadays, it's becoming increasingly seen in young adults. What about the body habitus? Because type 1 diabetes, they lack insulin, they lack the anabolic effect, and they have the unopposed catabolic effect, so they are often lean. But on the other side, type 2 diabetes people, they still have insulin. And اصلا يعني the cause of insulin resistance is due to their overweight and obesity, because obesity and overweight, they affect the insulin receptors, and they affect how insulin responses, or the effect of insulin. So they would be often overweight or obese. Regarding the insulin level, we said it's very low or absent in type 1. In type 2, it's normal or even high initially, then declines later when the pancreatic beta cells are burnt out and they die. Regarding the acidosis risk, we said that in type 1 it is very common, since you don't have the protective effect of insulin by reducing ketogenesis. In type 2, it's not common, it's low because you still have insulin, although you still have insulin resistance, but you still have insulin, so the risk of having ketoacidosis is much less. Regarding lifestyle response to lifestyle changes, it is limited because, in type 1, you just give insulin, and this is the fix. But in type 2 diabetes, you need significant lifestyle modifications, and with weight loss and like oral hypoglycemic drugs, these really significantly improve the insulin resistance. So what would be the main therapy in type 1? Lifelong insulin therapy, because they don't have insulin at all. What would be the main therapy for type 2 is lifestyle modifications, oral hypoglycemic drugs, as well as insulin. And focus more on the lifestyle modifications, because losing weight, it might actually fix the problem. So, what happens when there's insulin deficiency or severe insulin insensitivity? So, insulin is not there or it's not working. So, what would happen is that insulin is not doing its job. So, there would be decreased tissue glucose uptake. You cannot take glucose. There would be an unopposed effect of glucagon. So, there would be increased glucose breakdown, as well as glucose production. Um, and this all of these would lead to hyperglycemia and glycosuria. So these three components would lead to increased blood glucose. And when there's increased blood glucose, the kidney has a limited capacity of reabsorbing back the glucose amount. So the glucose would be in the urine, and this would cause osmotic diuresis, because when glucose gets lost, it takes water with it. This would lead to loss of water, as well as electrolytes like sodium and potassium. This would also lead to hypovolemia. Hypovolemia would be severe. If it's severe, it could even cause circulation failure. It could cause shock. The body is not able to perfuse the tissue. So this would lead to decreased tissue perfusion, and as a fatal consequence, it would lead to coma or even death. For the hyperglycemia thing, this would also increase the plasma osmolality, because you know that glucose is very high in osmolality, and this would make us feel that we're thirsty always, because there's a lot of sugar in the blood. You need to drink water in order to bring down the plasma osmolality. So that's why patients, they experience polydipsia. They want to drink water a lot. As a consequence also of unopposed glucagon effect, there would be increased proteolysis, because catabolism. This would lead to decreased protein and weight loss, and this amino acids gets incorporated into the glycogenesis pathway. There would be also decreased lipolysis, and this increases the plasma free fatty acids. As a consequence, because you have free fatty acids, and glucagon is the main guy right now, because you don't have insulin, or insulin is not working. So there would be increased ketogenesis. This would lead to ketonemia, or ketone bodies in the blood, as well as ketone bodies in the urine. These are acidic, so they would cause anion gap metabolic acidosis, and these would cause vomiting, and with vomiting there's also more loss of water and electrolytes. And with metabolic acidosis, as you remember, what is the compensation is respiratory alkalosis. In order to achieve respiratory alkalosis, there would be hyperventilation, or what is called cosmal respiration. Um, Also, as a consequence of circulation failure and tissues start to die, there will be also increased serum lactate. The serum lactate also adds on to the anion gap metabolic acidosis. Okay, so we mentioned everything here. Diabetes mellitus, you have polydipsia because you're always thirsty because of the plasma osmolality and as well as the osmotic diuresis. The polyuria, you always go to the bathroom because of the glucose. It takes a lot of fluid with it. Polyphagia, you're always thirsty, you're always hungry. And there's also weight loss, especially in type 1, because these are the unopposed effects of glucagon. While in type 2, there is hyperosmolar hyperglycemic state. We're gonna discuss it in a few slides. Also, diabetes could be caused by glucocorticoid therapy. We mentioned that the steroids are diabetogenic, so they cause diabetes later on. As a chronic complications, it causes retinopathy, neuropathy, nephropathy, a lot of effects on our body. You don't have to go into details. You're gonna learn it more in third year. So, and we talked about the difference between type 1, type 2. Type 1, autoimmune destruction of beta cells. Type 2 is more of an insulin resistance. And with time, there's progressive pancreatic beta cell failure, and the beta cells are burst out and they're burnt out. What happens is that usually type 1 is in the young adults as well as children, adolescents. Type 2 is more in the older side. And type 1, they always need insulin as a treatment. Type 2, lifestyle modifications and weight loss, and this would be a better option. Type 1, they are not obese, they are lean because of the catabolic effect of glucagon. Type 2, they are obese because of obesity is aslan like the cause of insulin resistance. Um, Regarding the insulin sensitivity, they are very sensitive. So the treatment would be just giving insulin. Type 2, they have low insulin sensitivity. Ketoacidosis is very common in type 1 because of the unopposed glucagon effect, and they don't have the protective effect of insulin. It is rare here because you still have insulin. Beta cells are destroyed, so decreased. It's variable because at first it's normal, then it increases, then it decreases. But at the end stage, the beta cells are gonna die if you don't treat it or you don't go with lifestyle modifications. Regarding the serum insulin level, it would be decreased. Type 2, it's variable. And the classic symptoms of polyuria, polydipsia, polyphagia, and weight loss is more common type 1. Type 2, it's sometimes more, usually type 2, we see them obese and you don't have these classic symptoms. Um, so moving on, how to diagnose diabetes. So diabetes could be diagnosed by three ways. We have the glycated hemoglobin or hemoglobin A1C. The cutoff is more than 6.5%, and this reflects how average blood glucose over the prior 3 months. So if it's over 6.5, this has the diagnosis of diabetes. We also check for fasting plasma blood glucose if it's more than 7 millimole per liter, or yani equal greater than or equal to 126 milligram per deciliter. Then we have a diagnosis of diabetes, but make sure that the person is fasting for more than 8 hours. Then we have the 2-hour oral glucose tolerance test. So first, we make the patient fast. Then we give him 75 grams of glucose in water. Then we measure the blood glucose after 2 hours. If it's greater than or equal to 200 milligram per deciliter, then we have the diagnosis of diabetes. Okay, so one of the most feared complications of diabetes is diabetic ketoacidosis, and it's usually happens in type 1 diabetes. Usually due to insulin non-compliance, the patient is not taking insulin, so you don't have this protective effect. Or there are increased insulin requirements. Whenever you have stress or infection or these conditions, you need more insulin. So this would make the person more prone to develop diabetic ketoacidosis. What would happen? There would be excess fat breakdown and increased ketogenesis, and this is from the unopposed effect of glucagon. We said that glucagon stimulates ketogenesis, so this would lead to increased fat breakdown, increased ketogenesis from the free fatty acids, And these are then converted to ketone bodies, the beta hydroxybutyrate as well as the acetoacetate. It's usually more common in type 1, as we said, because like type 2, they have insulin already. So this protects them in a way. Um, but they could still get diabetic ketoacidosis. Okay. So what are the symptoms? They have delirium psychosis. They have the decusmal respiration. We said because of the metabolic acidosis, they compensate by respiratory alkalosis. So they have rapid deep breathing. They have abdominal pain, nausea, vomiting. They have dehydration because of the vomiting and the osmotic diuresis. They have a fruity breath odor. This is because of the exhaled acetone. What are the labs? Hyperglycemia, of course, because you don't have insulin. Increased hydrogen as well as decreased bicarbonate, and this is due to the increased anion gap metabolic acidosis done by the ketone bodies. Um, if you measure the blood ketone levels, it would be high. Also, there's hyperkalemia, but this hyperkalemia is relative because you already lose potassium through urination and through vomiting. But because insulin, we mentioned that insulin is important in the shift of potassium from outside to inside. If there's no insulin, there would be increased potassium in the blood. Although overall you have low potassium. You get me? Because you're already losing potassium through vomiting and through osmotic diuresis. But relatively, you have high potassium because the potassium is shifted from inside the cell to outside, and insulin is the factor that brings it inside. But you don't have insulin, so there would be hyperkalemia from decreased insulin and also acidosis. And as we mentioned, that osmotic diuresis would lead to the loss of potassium, as well as it would lead to the total body potassium depletion. Okay. And it is very life-threatening because it could lead to cerebral edema, cardiac arrhythmias, as well as heart failure. Another feared complication of diabetes is the hyperosmolar hyperglycemic state. And this is more common in type 2, especially in adults who have limited ability to drink because, whenever people grow older, they forget to drink water enough. So people, elderly who have type 2 diabetes and they have limited ability to drink, they are more prone to the hyperosmolar hyperglycemic state. What happens? From its name, they're hyperosmolar, hyperglycemic. There's a lot of blood sugar in the blood, and this is causing the blood to be hyperosmolar. So hyperglycemia happens. This would lead to excessive osmotic diuresis. So because of high sugar, this would get excreted through the kidney, and the kidney would take water with it, or the glucose is gonna take water with it. So this would lead to dehydration. And since they don't drink water enough, this would lead to the onset of the hyperosmotic state, hyperosmolar hyperglycemic state. What would be the symptoms? Thirst, because they're not drinking water enough, and they have a hyperosmolar state, so you always feel thirsty. They have polyuria because of the osmotic diuresis. They have lethargy, focal neurological deficits, because when there is a lot of glucose in the blood, the fluid is gonna shift to the blood. So fluid from the brain, there would be that would affect the fluid homeostasis in the brain. This would lead lethargy, focal neurological deficits, also seizures, and even progress to coma and death if left untreated. So what would the lab show? Hyperglycemia, because of the type 2 insulin resistance, as well as increased serum osmolality, because glucose has a high osmolality effect, as well as there is no acidosis because you still have insulin. So in order to differentiate between hyperosmolar hyperglycemic state and diabetic ketoacidosis, there's no acidosis, there's no ketone body production, because there's still insulin that protects the person from ketogenesis. And for the treatment, you give IV fluids, and you don't have to know the treatment. We have two tumors. We have the glucagonoma and the insulinoma. Starting with the glucagonoma, which is basically a tumor of the pancreatic alpha cells. because the alpha cells are the cells that produce glucagon. There would be overproduction of glucagon, so they would present with dermatitis, which is also called necrotic microartery erythema. Since there is overproduction of glucagon, you would find over exaggeration of the glucagon effect. So there would be very high levels of glucose, and this would cause diabetes because of hyperglycemia, as well as they have declining weight because of the catabolic effects of the glucagon. The treatment is basically to stop this tumor. You give octreotide, which is basically a somatostatin. And we talked about the delta cells, they produce somatostatin that stops the glucagon or stops alpha cells from producing glucagon. For insulinoma, it's basically the tumor of pancreatic beta cells. So there would be overproduction of insulin. So there would be over exaggeration of insulin production or insulin effects. So there would be hypoglycemia. So what would we find? Low blood glucose, symptoms of hypoglycemia like lethargy, syncope, diplopia, and also um, whenever the treatment is basically we give like the acute treatment is the normalization of blood glucose levels when we give glucose. Um, Treatment is surgical resection. You don't have to know it, but a clinical aspect is that since there is endogenous insulin production, very, very, very much, this would lead also to the increased production of C peptides, and helps us whether this increased insulin in the body is due to an exogenous source or an endogenous source. Okay, we mentioned the difference between diabetic ketoacidosis and hyperosmolar hyperglycemic state. Go over it real quick. You don't have to know everything, but just know the high yield. So, what are the physiological basis of diagnosis of diabetes? We already mentioned this. We already mentioned that normally there should be no glucose in our body because the kidney has the facility or yeah, the facility of reabsorbing all glucose in the blood back. But in diabetes, because they have an extremely high level of glucose, the enzymes or the transporters in the kidney are limited. They have limited capacity, so they cannot reabsorb all glucose. So they would still, patients with diabetes mellitus, they would still have glucose in the urine. This is something to note. And normally, in normal people, the normal blood glucose levels are kept between 80 to 100, 110. But what happens is that when you give or when um, you give sugar, the blood level of glucose rises to around 120 to 140. Then after 2 hours, it goes back. Whenever you want to do the oral glucose tolerance test is when you give glucose and you measure the glucose level after 2 hours. Look at this difference between normal and diabetes. Normal people, they have the fasting blood glucose around between 80 to 100. So this is normal. Then you give them the oral glucose and you have a rise in the blood glucose to around 120, 140. Then it falls back to normal within 2 hours. But in cases of diabetes, you already have a high fasting blood glucose level. And when you give glucose and you measure the rise, there would be a rise more than the normal. So levels of 185, 165, 140. And even after a few hours, after 2 hours, like after 2 hours, it would still be high. And this is how you diagnose diabetes. And even after 4 to 6 hours, it would still be high. So it would not normalize. So patients with diabetes, they have constant high blood glucose levels and they cannot control it or maintain it or regulate it. What about the insulin secretion in response to hyperglycemia? So insulin secretion occurs on two phases. You have the immediate response and you have the gradual release. So when you eat a meal that has glucose, what happens is that after a few minutes, like within like few minutes, the insulin spikes there's a first spike. This is the immediate response. Within seconds to minutes, there is the release of the already stored insulin in the beta cells. We mentioned that beta cells produce insulin in secretory granules. So the moment the blood glucose level rises, there is a spike of insulin, and this is due to the immediate release of the available insulin stored in the beta cells. Then, with time, there is gradual release, and this happens like 15 minutes to till like 2 to 3 hours after the meal, and this is due to insulin still being produced. So what's this sudden, this gradual increase is due to the newly produced insulin, newly sensitized insulin that gets secreted by the beta cells. If you want to compare the normal with the abnormal. In normal, you have the first phase, second phase. You have the spike, then you have another rise, then it gradually goes back. In type 1 diabetes, you don't have any spike, you don't have anything, you don't have insulin. So there's no spike, there's no immediate response or even gradual response. And type 2 diabetes, they don't have the immediate response because of the sensitivity. They don't sensitize glucose well. Like they need like a very high glucose level in order to be sensitive. So what happens in the first phase, it does not even rise. Nothing happens. But with time, because there's difficulty in sensitizing the blood glucose levels, it starts to gradually rise, but not as much as the normal. But there is still a response, but it's minimal. And this is due to how the body does not sensitize, or the body is not sensitized to the glucose levels in the blood. Okay, so just to recap, normal, you have immediate response, then gradual release. Immediate response is due to the already produced insulin in the beta cells. Then the gradual release is from the newly produced synthesized insulin. In type 1 diabetes, you don't have any response, neither first phase or second phase. In type 2 diabetes, you don't have an immediate response because uh, like the body is not sensitized to into blood glucose. It needs much higher blood glucose than the normal, blood glucose levels than the normal in order to sensitize. And yeah, there is high blood glucose. So there would be a minimal gradual release in phase two. Okay. Just to recap really quick, what would be the effects of untreated diabetes on carbohydrate metabolism? We see that there is decreased insulin secretion, or there's insulin resistance. What happens is that this would lead to decreased glucose uptake and utilization, because we mentioned that insulin it increases glucose uptake and utilization. So if you're not taking in glucose, the blood glucose would rise, so there would be hyperglycemia. Also, there would be an unopposed glucagon effect. So this would lead to the rise, even the body is raising blood glucose levels more and more and more. So there would be glycogenolysis and there would be gluconeogenesis, and this would also increase the blood glucose levels. As a consequence of hyperglycemia, there would be excess glucose in the blood that cannot be reabsorbed by the kidney. Then the glucose would go through the urine, excreted by urine. So this would be a condition called glucosuria, and with glucose in the urine, it would lead to decreased tubular reabsorption of water, because with sugar, water follows. So if there's decreased tubular reabsorption of water, this would lead to polyuria. You always go to the bathroom and urinate, and this would lead to hypovolemia because you're not reabsorbing water back. So this would lead to hypovolemia, as well as there would be dehydration of the extracellular fluid, because you're excreting fluid, so the extracellular fluid wouldn't be sufficient. So there would be the dehydration, and this would lead also to polydipsia, or like the feeling of thirst. Also, as a consequence of hyperglycemia, this would increase the osmotic pressure of the blood and extracellular fluid, and this would shift the water movement from inside the cells to outside the cells into the ECF. This would cause cellular dehydration, and this would also cause polydipsia. And this shift would cause extracellular fluid expansion that will later be get excreted by the kidney because of the osmotic diuresis. Okay. What about the protein metabolism? We mentioned that insulin is an anabolic. So if there's no insulin, it means that there's increased protein catabolism. There's decreased amino acid uptake in target tissues. And there's decreased protein anabolism. Regarding this would lead to increased plasma amino acid concentration. So this would get the body would use this increased plasma amino acid concentration to increase glucose by gluconeogenesis, and also there would be increase of proteins for energy in tissues, and this would like the tissues would use the urea cycle, and this would lead to increased urinary excretion of urea. Because there's more catabolic effects, there would be loss of lean body mass. You're gonna lose muscles and proteins, and this would also lead to asthenia or weakness in the body. What about lipid? There would be decreased insulin, so there would be unopposed effect of glucagon. So as a result, there would be activation of hormone-sensitive lipase, and you would break down triglycerides. This would release fatty acids and glycerol into the body. So these free fatty acids are converted into phospholipids and cholesterol. So this would lead to the increased lipoprotein concentration in blood, and that's why as a effect, this cholesterol would deposit in the arterial wall, and that's why when patients have diabetes, they are also prone to hyperlipidemia and atherosclerosis and these things because of the conversion of free fatty acids into phospholipids, into lipids, and cholesterol in the liver, and this would lead to the production of more lipoproteins, especially the LDL or the VLDL, and this would lead to deposition of cholesterol in the arterial wall and causing arterial atherosclerosis and hyperlipidemia. Also, the free fatty acid is used as energy in all the tissues, and as a consequence of the release of fatty acid and glycerol, this would lead to the increased fatty acids in the liver, as well as the oxidation of fatty acids in the mitochondria. All of these would increase the synthesis of acetyl-CoA, and acetyl-CoA then gets converted to ketone bodies, and the ketone bodies are going to be utilized in tissues due to the lack of insulin. And if we have ketone bodies, this would lead to also can increase concentration of ketone bodies in the blood. This would lead to ketoacidosis, as well as the ketonuria and acetone breath. One condition to go over is hyperinsulinism and hypoglycemic coma. What happens is that there's increased insulin in our body, and this excess could be due to insulin overdose, so exogenous insulin, you took like an overdose, or you took an overdose of hypoglycemic drugs, the drugs that could cause hypoglycemia, or there's an insulin secreting tumor like insulinoma. What happens is that there's increased insulin, so this would lead to the increased peripheral glucose uptake via the GLUT4. Think of it as exaggerated insulin effect. So there would be more translocation of GLUT4 transporters, as well as there would be increased peripheral glucose uptake. Also, there would be decreased hepatic glucose production because there's no need to produce glucose. So this would lead to hypoglycemia, and mainly it affects the brain, because we mentioned that the brain only uses sugar, and if there's no enough glucose in the blood, it affects first the brain because it's the most vital organ. So if the blood sugar levels are between 50 to 70, there might be some nervousness, tremors, sweating, hallucinations. If it's even less, between 20 to 50, this would lead to CNS depression. So patients would experience seizures, decreased muscle tone, loss of consciousness, respiratory depression. And in case of like severe untreated hypoglycemia, this may cause permanent brain damage or death. So what are compensatory mechanisms or responses that we have? We have the sympathetic nervous system, as well as the hyperglycemic hormones. So things like cortisol, things like epinephrine, norepinephrine, glucagon. So what would be the response? Increased glucagon, increased sympathoadrenal activation, like cortisol, all the hormones that raise the blood glucose. So as a result, there would be increased glycogenolysis, and breakdown of glucose by the liver, as well as lipolysis to be a source used by the organs. There would be decreased peripheral glucose uptake because one of the problems is that there's increased peripheral glucose uptake. So you need to fix this problem by decreasing the peripheral glucose uptake and making sure that there's enough glucose to be used by the vital organs like the brain and RBCs and the retina, etc. So later there will be increase of cortisol and growth hormone, and these are also help in raising up the blood glucose. As a treatment, you give IV glucose 50% to restore blood glucose levels as soon as possible before causing permanent damage to the brain or death. Okay. Just for the sake of completion, you have another condition which is metabolic syndrome. I don't think it's high yield that much, but it's basically memorization. It's a cluster of metabolic risk factors that increase the risk of cardiovascular diseases as well as type 2 diabetes. It has a diagnostic criteria. So any presence of three of the following would diagnose a patient having metabolic syndrome. So abdominal obesity, in which if the waist is greater than 102 centimeters in men or 88 centimeters in women, you have abdominal obesity. If there's hypertension, in which there's increased one blood pressure by 130 to 80 millimeter mercury. This is also one of the criteria. Low HDL cholesterol. So you have decrease like less than 40 milligram per deciliter in men or 50, less than 50 milligram per deciliter in women. If there are high triglycerides more than or equal to 150, if there's elevated fasting blood glucose more than 100, or there's existing type 2 diabetes, any three of these would diagnose a patient of having metabolic syndrome. And just a concept, it's often called deadly quartet because it includes the four big guys. So you have abdominal obesity, hypertension, insulin resistance, and dyslipidemia. Um, three of these would establish the diagnosis of metabolic syndrome. Just recap the consequences of insulin resistance, why insulin resistance is deadly or severe and should be treated. Basically, it increases appetite because you know that insulin decreases inhibits neuropeptide Y. So if the insulin is not functioning, this would lead to increased appetite, and you would become more obese and more obese and more obese. This obesity is gonna affect the insulin resistance more, so it's a vicious cycle. The arteries, this would lead to increased plaque formation, atherosclerosis, stroke, MI. This is due to insulin resistance and insulin not being able to function well. For the liver, it's going to increase lipogenesis, so you would have a fatty liver, as well as it would increase the glucose production, so it would raise the glucose levels in the blood. The pancreas, with insulin resistance, the beta cells are gonna proliferate and try to compensate, and they're eventually gonna try to raise the insulin levels, but at the end, they're gonna get tired and they're gonna die and burst or burn out. So the B cell survival would decrease. Regarding abdominal fat, there would be increased triglycerides, there would be decreased lipolysis, and all of there would be fat accumulation around the abdomen. Also, there would be resistance in the vessels because the vasodilation would decrease. We mentioned that insulin has an effect in vasodilatory effect by stimulating nitric oxide. So if you don't have this effect of insulin, there would be decreased vasodilation. So there's would be increased vascular resistance. So another consequence of diabetes is hypertension. So think of diabetes, hypertension, as well as hyperlipidemia as like a group of diseases happening at the same time. Regarding muscle, there would be decreased glucose uptake, and there would be also decreased glycogen synthesis, and there would be muscle wasting, of course, and muscle breakdown as a consequence of insulin resistance. And that's basically it. That wraps it up for both lectures, the adrenal as well as the pancreas. I hope you guys enjoyed and benefited from my explanation. Like if you have any questions, any things you want me to explain, Please don't hesitate to ask or contact me. I have my phone number at the beginning of the slides. Um, and yeah, best of luck to your exams. Inshallah, it's gonna be easy. Just focus on the high yield topics and don't overwhelm yourself that much. Inshallah, it's gonna be easy. And if you have time, just scan the code, and I would love to hear a feedback. I'm open to feedback, what to improve, what to limit. And yeah, thank you so much, and have a good day. Bye. Au revoir.